and I work at 5016 Street. Got a bit of a sore throat. I've checked. It's not a symptom of coronavirus, so I'm not going to be the kind of typhoid Mary of the conference, please. We've got 5 presentations this afternoon, which are a subject quite dear to my heart about how you get PrEP to high-risk communities. So I think they're all look really interesting. So I want to, first of all, welcome Dee Wang, who's going to talk about accessibility in London and factors that affect people's access to PrEP. She gave a great talk this morning, so I'm sure she'll do the same this afternoon. So, Dee.
Sorry. All right, so let's start counting. What I'm going to talk to you about this afternoon is the PrEP Champion project we've conducted between December 2017 and the end of 2018. So it was a one-year project that is funded by Innovation Fund from PHE. So back again, who is GMI? I know some of you are here this morning and had the opportunity to watch that video, so I don't want to replicate that again. I'm just going to quickly verbally go through what is GMI. So GMI is a partnership of 3 London-based organizations, which was funded in 2008. The 3 organizations are Metro Charity, Positive East, and Spectra. Together, we form a pan-London coverage of service delivery. We have been delivering counseling, outreach, mentoring, and HIV testing and STI screening over the last 11 years. We've been able to deliver more than 4,000 sessions across London in over 150 venues. So we reach over half a million sort of individuals during the past 11 years. So back to the PCP project. So the project is actually a collaboration between GMI Partnership and the PrEPsters. This 12-month project was aimed to train and deploy community PrEP champions alongside our routine, regular sessional workers, outreach staff. So we are targeting men who have sex with men and women, and heterosexual BAME men, and people with trans experience. So the objective of it was to increase knowledge of PrEP and increase knowledge of how to access PrEP, and to decrease stigma associated with PrEP usage, and to increase in access to PrEPsters' website, and increase professional awareness and expert knowledge around PrEP. So in that 12-month period, we managed to train 54 PrEP champions. And so with these champions, we delivered over 170 sessions that is mainly focused on the PrEP sort of discussion. And then we reached actually over 1,000. The detailed number is 1,124 people. Among them, 1,056 is actually belongs to the target group we just mentioned earlier. We also delivered 12 agency training for people actually come into contact with possible high-risk groups. And also, PrEPster managed to sort of develop the comprehensive outreach fact guide based on the champions' sort of feedback and their questions and their sort of first-line work. So this is some of the bulletin and some of the photos they taken during the project. So result. As you see, we mainly categorize people into white MSM, BAME MSM, white woman, BAME women, and the trans and heterosexual BAME men. And you can see there is quite a bit difference when we ask people whether they've heard of PrEP before. Overall, less than half of them have heard of PrEP, and the majority obviously lie in the MSM population. You can see like heterosexual BAME men a significantly lower level of knowledge about PrEP at the time. And we also ask people, do you know anyone that's using PrEP? Not surprisingly, the percentage is even lower. Even within MSM communication, that percentage is not extremely high. It's like just over 50% actually do know someone's using PrEP. So when we ask about people's attitudes around PrEP use, like how would you think you will use PrEP? We get pretty much about just less than half of people will say they will use PrEP. There is over a quarter of them saying maybe not, it doesn't really matter to us. But there are considerably, nearly 20% actually says no, we're not going to use PrEP. And we break these answers down by different sort of target groups. We've noticed, interestingly, women are less likely to say no. They get a really small portion to say no straight away, but it doesn't mean they say they're going to use PrEP for sure. They actually also have a smaller chunk to say that for sure they're going to use PrEP. A majority of women's responses actually, I don't decline it, I don't say no, but I don't think I need it. So we during the conversation, the interview with people, it feels like, it seems like women are quite used to have this daily dosage sort of regimen, and so they don't sort of against that thought about using medication every day. On the other hand, they don't perceive themselves have high risk in general. So this is one of the interesting findings we have. And also for trans people, there's a quite big chunk of trans respondents say they are not going to use PrEP. When we dig deeper later on, quite a lot of them actually respond they are worried about the side effects because the hormone treatment and everything. So I hope you can see this one clearly. We break down their reasoning of why they will or will not use PrEP. The majority of them is still kind of positive, and over 2/3 of PrEP supporters think the PrEP reduces anxiety around HIV requisition, and 60% believe PrEP provide individuals with an extra safety option, and 1 in 5 of them actually believe PrEP enable them to have sex without condoms. So that is something we actually need to look into. Into the negative side, that's this bit. There's a lot of people actually didn't really give us reasons. Over a quarter of them actually criticized they were afraid of the possible side effects. 1 in 5 of them spoke about stigma associated with PrEP using. So because they think using PrEP might indicate high risk and then the multiple sex partners. And then the middle chunk, the indifferent bit, the majority actually kind of claim that they don't really have high-risk sex. That's why they don't think it's relevant to them. And 1 in 5 stated that they prefer using condoms. So, yeah. So we also asked people, what's the major barriers and motivators if we want to promote PrEP use in the community? The major barriers being identified is about information knowledge. Basically, 44% of all respondents actually tell us that they think there's not enough information or correct, accurate information in the area. So that's why that's a major reason they think people are not accessing it. And over 1/3 believe the cost of PrEP will be a burden to many people. And nearly 1 in 5 thinks PrEP does not provide against STI and a possible kind of encouraged condomless sex. That could be one of the barriers for people not using, consider not using PrEP. And 14 concern around consistent availability, because they don't want to start it and then they run out of medication and they think they were afraid of that. It won't protect them anymore. And the 12% actually thinks stigma and the discrimination around PrEP users is going to be the main barrier. And then back to the motivators, people said up-to-date information is essential. That's over half of the respondents. 53% actually agree with that. And the PrEP will better receive if it were free or with a lower cost. That's about 38%. And accessibility was important as promotion. 16% of people actually think, although there's information, but it's vital that the medication is also available. And having clear criteria for PrEP use will encourage people to identify their own need and thus improve PrEP uptake. That's 8%. So there is a full PrEP PCP report which is available if you want it. It's a long report. So if you want any of these full reports, feel free to contact us and we will be able to send that to you. There is a whole chunk of evaluation about the project itself. That's including some qualitative result about interviewing participants and interviewing the PrEP champions. That's all in that full report, so I'm not listing that here. We do have some message I think it's probably worth for you to just highlight in this presentation and take it home with you. So basically, less than 1 in 2 people has heard of PrEP, and especially low level of awareness among BAME heterosexual men. Most will use PrEP when needed. However, the percentage were lower among women and trans people. And the factors of PrEP use including cost, knowledge, accessibility, and availability. So this is the end. I would like to thank the Commissioner, Innovation Fund from PhD, and also PrEPster, who actually help us to deliver the training and help us to equip our champion and then come up with this brilliant sort of resources that's available on their website. It's well here. I believe it's available on their website for anyone to use if needed. Thank you.
Thanks, Amelia. Fabulous, thanks very much, Dee. So I'd like to invite Amelia Thorpe to the stage. She's from Yorkshire MESMAC, and she's going to be talking about the MoPresh initiative targeting women. And I'm just trying to find her talk, which is here. There you go.
Thank you, Alan. Good afternoon, everyone. So I'm Amelia Thorpe. I work for Yorkshire MESMAC, and I'm going to be talking about the MoPresh project this afternoon. So just to give you a little bit of background of the project, it was funded by the Public Health England Innovation Fund, and it ran for 12 months throughout 2019. The project ran across 3 locations. It was led by PrEPster in London, and then 2 partner organisations, Brigstow and Yorkshire MESMAC, ran the project across Bristol and Yorkshire. The 2 partner organisations had 6 months each to run the project. So I'm sure in this room we all know that we have lots to celebrate when it comes to HIV in the UK. We've reached the 1990 targets, and we're seeing decreases in new HIV diagnoses. And we also have the tools to prevent new transmissions as well in PEP, PrEP, testing, condoms, and HIV treatment. So these are great achievements, but we have to look a little bit more closely. So in the UK, around 1/3 of people living with HIV are women. More than 1/4 of people diagnosed in 2018 were women. And then when we look at the PrEP impact trial, only half of the places ring-fenced for women were filled, and women account for only 4% of the total participants on the trial. So that's where MoPresh comes in. So MoPresh aimed to address the numbers of women accessing PrEP across England in the 3 areas that we were covering. And this was specifically within women in communities most affected by HIV. So they were black women, other women of colour, trans women, speakers of other languages other than English, and sex workers as well. So what MoPresh aimed to do was to get women in their communities talking about PrEP to each other. To achieve this, a peer mobilising model was adopted. Okay. So how we went about that, well, the first stage in all 3 areas was recruitment of the women. We did that in a number of ways, including word of mouth, using social media to advertise the project, and approaching organisations that we already work with, that work with those most at-risk women. All women who expressed an interest then attended training, This covered HIV in general, PrEP, and decolonising sexual and reproductive health, STIs and contraception. Following the training, all the women were then supported by project staff to design and implement their own interventions within their communities. This resulted in a variety of interventions. A key part of that was doing outreach at community events, and our peer mobilisers went to a number of events throughout their areas, including Pride events, Carnival events, and other significant days, including International Non-Binary Day. Some other peer mobilisers chose to deliver workshops or more informal one-to-one sessions and group discussions to get the word about PrEP out there. And then another key aspect of work that the peer mobilisers did was delivering promotional materials in public spaces. Hairdressers were used in all 3 locations, so PrEP postcards and things were left in prominent places, and conversations were had with the staff in the hairdressers, so they had basic knowledge as to when their clients asked about it. They had a little bit of a spiel to say, kind of thing. They were also left in public toilets and things like that. We had a peer mobiliser who was really passionate about getting HIV messages to deaf people. So she produced a YouTube video that compared PEP and PrEP, and she did that in BSL. So it would be accessible to BSL users. At the moment, at last check, that video had about 600 views since it was uploaded, and she has uploaded another video this past weekend explaining U equals U again in BSL to make that accessible. And finally, the group in London produced a zine called Swallow It Whole, which they all contributed to, and it was a real community effort between the peer mobilisers. That zine is still available. It's available downstairs at Prepster, on the Prepster stall downstairs if you want to have a look at it. And it is available as a downloadable resource online as well. And we hope by having YouTube videos available and the zine still available, they can carry the legacy of the project forward beyond the time frame that we were given. So outcomes then. So the project was successful in recruiting and training peer mobilisers in all 3 locations, and a variety of interventions were carried out across London, Bristol and Yorkshire. And the women came back and said they felt empowered to engage and take charge in discussions around HIV and PrEP as well. So recent figures show that the number of women on the PrEP impact trial is increasing, but we would need to look further into whether any of the new women on the trial had any interaction with mob PrEP interventions in their areas. And also, we're not sure of the numbers of women buying PrEP privately as well, so we'd have to look further into that. And in terms of peer education, it is sometimes a little bit difficult to look at the impact of the project as soon as it ends. And this was put really nicely by one of the project staff members. And she reflected on the fact that she started her work 25 years ago on a peer education project, and she's still working in HIV prevention today. So who knows what some of our peer mobilisers will do going on into the future. So key learning then, I think the main issue that came up across all 3 areas was time. As I said, in the London branch of the project, they had 12 months, and in Bristol and Yorkshire, there was 6 months, which was quite challenging to recruit, train, and then implement in the time scale, particularly in the 6-month time frame as well. We did also reflect on the time of year that we had to do the project as well. So in Bristol and Yorkshire, the project ran from April to September, which is obviously across summer, which created additional barriers for some people engaging in the project, particularly with childcare during the big summer holidays for children, and with Pride events throughout the summer as well. We had a number of people not taking part because they were already active in Pride events and things like that. So whilst the project in all areas was successful in recruiting black women, there were some challenges faced when recruiting some of the other key populations, particularly with sex workers and trans women and non-binary people as well. So we had to have a bit of reflection on this. Part of it might be due to the kind of hostile environment that's at the moment, with a kind of increase in anti-sex worker rhetoric and transphobia that's going on at the moment. We were asking women to prioritise taking part in a sexual health project where really their energies were best spent elsewhere. So we had to think about that as well. And also when trying to recruit non-binary people, it's a very women-focused project in terms of the language that was used. So if we were to do it again, we would work with non-binary people to help word the promotion of the recruitment drive a bit better as well. We also found that on reflection we needed to set explicit and clear goals in terms of what peer actually means. There were some concerns in Bristol and Yorkshire about whether focusing the project particularly on black women, that it may be stigmatising or discriminatory for that group. So because the project centred around the peer mobilisers, I thought I'd give the last word to them really. And as you can see, the peer mobilisers themselves learned a lot about PrEP and HIV and sexual health more generally by taking part in the project. And they all fed back that when they took that message to their communities, very few women they encountered had heard of it either. And finally, many peer mobilisers expressed that they wish they could do more beyond the project. The funding's ended now, but they wanted to carry on this work further. But they were very aware that once the funding's gone, the resources kind of dry up. So we are very keen for this kind of work to continue in the future. Thank you very much.
Thanks, Amelia. That was great. So I now would like to welcome Greg Owen to the stage, please. So obviously, Greg is well known to an awful lot of people as the man who's one of the two people who set up I Want PrEP Now, and he's now the lead for PrEP at THT. And Greg, do you know which is your talk? It's on the desktop. I'll let you find it. Thank you.
Please work. Okay, here we go. Okay, my name is Greg Owen. I'm the PrEP lead for Terence Higgins Trust, and I'm also co-founder of I Want PrEP Now. This data that I'm about to present was presented in a previous conference, BASH last summer, and we had 8 weeks of data then. The 8 weeks of data that we had were heavily targeted, had heavily targeted social media advertising and mainstream media advertising. So the data has now been updated to include from the 14th of December 2018 to the 31st of December. So to give you a little bit of background, we have variable access to PrEP in the United Kingdom. I don't think I need to labour that point. Everyone in the room knows that. Scotland is the only place that currently has a commissioned service through specialist sexual health services, and England remains the only country of the devolved nations that does not have open access. We currently have a capped trial. So, we don't really have any way of knowing if self-sourcing PrEP users are self-managing well. What we do know is that they're predominantly white, so it was a Public Health England Innovation Fund that funded this work, and the objectives were to offer information, advice and support, and to facilitate both access to and safe usage of PrEP. The key objectives were to target Black African communities, trans people, and heterosexual people at parity of risk to MSM, who had up to that point been underserved. So, let me just have a little. Okay, so basically, talk you through the tool. So there are 3 options on the tool. The first option is an eligibility function. So you'll work your way through a logic tree, and you will come to an exit page that gives you advice on whether you should or should not consider taking PrEP. We also did a very similar logic tree for stopping PrEP, but the data that I'm about to show you is from a pro forma. So the I'm already on PrEP and how do I take it correctly actually was a form that the user filled in, and depending on what answers they selected, they would get a very tailored output. So it was a very user-focused front-end tool. So the data that I'm going to show you lacks a little bit of nuance and may be biased due to where it sits. Oh dear. So this is the pro forma that I was talking about. I'm going to skip through these demographics quite quickly. There is no surprise that the majority of people that found their way to this traffic were white gay men. I spent almost £5,000 on targeting adverts to anyone but white gay men, and still white gay men remain incredibly engaged on online PrEP material. It is worth pointing out that total traffic there, the 21,153, about 10,000 people from that traffic actually were captured in the first 8 weeks. So the 8 weeks of highly targeted social media advertising yielded almost the same volume of views as a whole subsequent year almost. So work in your budgets for advertising. So if we take a little look at the total traffic, we can see, again, men who have sex with men are the predominant group there. And we have started to see some women, heterosexual women, take up PrEP within that group. So if we have a little look, an overview of how people are testing, where they're sourcing, and we'll talk through this data. So you would expect this not to look like this. As I said, it might be slightly biased because this is a tool that sits on I Want PrEP Now, and if you're on I Want PrEP Now, you're probably looking to buy generic PrEP. However, of the respondents, only 27% were getting their PrEP through the NHS or a trial. Private prescription was 20%. That doubled over the course of that year. I'm not sure whether it's because we listed a private regulated pharmacy or whether 56 Dean Street's PrEP shop started to pick up significant numbers. But what we can say for definite is that this current situation is not acceptable. So if we look at dosing, the majority of people, 45% of people took PrEP daily, 37% on demand, and 17% of people were taking the T's and S's at least 4 pills per week. Slightly concerning was when I went through this data last week, was there was an open text box which didn't yield too many results previously, but there were quite clearly people who are not dosing correctly. One person got PrEP confused with PEP, but there were some concerning incorrect dosings. So if we have a look at baseline tests, so 85% of people had a HIV test at baseline at clinic. Self-test, with 11% of people. I guess any HIV test is better than no HIV test, but your self-test, we had no way to identify if it was self-sample or self-test, so there may potentially be people using a third-generation HIV test, which is not what we recommend. There would need to be a 4th generation. And again, and consistently, we see that quite a large proportion of people did not have renal function testing on commencing PrEP. So, monitoring for HIV and STIs. So the majority of people self-managed very well and did as per guidelines. A significant number of people, I'd say 19%, didn't. This is based on quarterly testing. 5% of people rarely or never test, and that's including everything. So there are 185 people who answered this survey who have not had a baseline HIV test or regular testing while using PrEP, so slightly concerning. So the conclusions. We designed a tool which worked and gave a very tailored intervention. It did reach the desired audience, and it has subsequently reached a wider audience. Ordering online demonstrates a huge amount of unmet need for PrEP provision. Most people are self-managing well, but we've just seen from the data that some people are not, and it does give cause for concern. Something that's coming up so I also manage the Mag Sportman PrEP Access Fund at Terence Higgins Trust, which is a fund which provides free PrEP in effect to people on low or no income. Now that's a very specific type of group, but what I'm noticing in my interactions with those clients, and as a result of some surveys that we've sent out to that group of people, getting PrEP commissioned in England is just the start. So we need to make it much more accessible. We need to be looking at new delivery models, potentially a PrEP at home service. It's great news that we have the 6 monthly checks with the e-service now for PrEP Impact in England, but we need to do better. We need to be more innovative. And are we slightly too restrictive with PrEP users? Are we creating barriers that don't need to be there? I would say potentially. And I will leave you with that. Thank you.
Thanks, Craig. That was great. It's great to see that so many people are managing to sort out their own monitoring. That's great. And so few people aren't. So that's really interesting. So I'd like to welcome Judy Oti to the stage, please. Judy works for the African Advocacy Foundation and is going to be talking to us about the, I've said a memory blank, what's it called? The PrEP and Prejudice Project. Which is your talk? Perfect. Lovely. There you go.
Thank you very much. I'm talking about the PrEP and Prejudice project that was funded by Public Health England under the Innovation Fund. A bit of background, it was mainly aimed to influence how Black people, Black African communities engage with HIV prevention tools, especially PrEP. It's consistent of 6 grassroots organizations, which are AHPN, Embrace UK, FAWA, which is a French-speaking organization, House of Rainbow, which is LGBT, BME LGBT, AGRA, which is more African, and the lead organization, African Advocacy Foundation. Our approach was to create unique messaging, specifically universal to African populations, using phrases that recognize and resonate with that community, have a community-based campaign, using community faces, engaging resources, digital content, and a tailored website specifically for this community. Our outcomes were to clearly understand the perception and attitudes of PrEP in the African community, especially with the low uptake we've seen on the impact trial and in all the other sources of PrEP, was to have an open discourse of PrEP among Black African communities, utilizing culturally, in a culture context, using innovative and cost-effective approaches, as well as co-produce successfully and launch this campaign within the community so that it can be disseminated in different social media and other channel platforms. The methods that we used were to develop a campaign increasing and sustaining awareness of PrEP among this community, especially to destigmatize PrEP and encourage uptake, mainly to the main channels, you know, the impact trial, Dean Street as a clinic that prescribes PrEP, and buying it privately, safely in using NHS recommended sites, as well as PrEP, I Want PrEP Now. We used innovative digital content that we produced using unique scripts. You will see, I'll show you later, a few of the posters and stuff we came up with that are universally recognized by this audience, and most importantly, that can be shared within the networks that are used by this audience. Especially we found a lot is done through word of mouth, through WhatsApp, through radio shows or online radio stations, online Facebook platforms, and that's what we wanted to capture. We also did educational activities mainly for frontline healthcare workers who work with the BME communities. We made sure we evaluate these by activities delivered, attendances, the knowledge of PrEP before the training and knowledge of PrEP after the training. A lot of questions were around the side effects of PrEP and how they can access PrEP. The outcomes of this project, maybe I didn't say at the beginning, it was last year, 2019, finished this year. 32 community PrEP champions were trained. 68 frontline health workers were engaged in PrEP as an prevention tool. We had 4 focus groups that helped gauge the baseline knowledge of PrEP. 3 of those were heterosexual, 1 was an BME MSM group. We also held 3 pre-production focus groups to identify the key messages. We narrowed it down to 4 key messages, and I'll show you again later. And we also agreed on using community faces, and I'll tell you when you see them why we went for that approach. We've delivered designed posters and leaflets and T-shirts, and also carried out 8 PrEP awareness workshops in London and inner cities, and have worked successfully with partnerships like PrEPster, THT, Mambo Magazine, the Impact Trial, and something that has also really worked well was online interviews or hosting us on online Facebook and radio stations with Dr. Vanessa and Dr. Felicia. That was very productive. So what we have produced out of it, the outcomes, a video that is on our website, that sits on our website, that is downloadable and shareable, a jingle that we can play on radio stations or TV, a slideshow that can be easily used in workshops on, again, Facebook platforms and stuff. We've produced a trainer manual with guidelines for PrEP educators. We've produced a campaign, we've produced a PrEP campaign website which provides support in a very easy to read, easy English to comprehend for this target community to understand, it has why PrEP, why that community, where can they get it, what are the side effects, and things like that. We've done over 30 outreach events, including 3 LGBT, MSM, BME events. We've had 5 referrals onto the PrEP trial and 1 to Dean Street. We have recruited 3 Black African PrEP user champions, and this is something we've realized is key, according to the feedback we received, that it would be good to see people who have used PrEP who can talk about their experiences. If this is shared, it will give people more confidence to use PrEP. We've done Facebook, like I said, Facebook Live and online radio station interviews, and to date, this was produced 3 weeks ago, we had reached 66,000 plus people. We've come to about 70,000 now, through social media and a direct and indirect engagement. The key findings from this project were from working with the frontline staff and volunteers, it was shocking that 32% of these didn't even know what PrEP stands for. These are healthcare professionals, these are people working in the community, these are people engaging with the BME community, and they didn't know what PrEP was. 22 of these didn't know the difference between PrEP and PEP. And then 53 did not know anyone who had accessed PrEP. And for me, the interpretation to this was either there's stigma, there's no open discussion around PrEP. So even if people are accessing PrEP, this is not information they share openly. Then what was also interesting is before the training, we measured knowledge of PrEP, and 55% scored 5 and below. This was a score out of 10, and after the training, 97 scored 6 and above in terms of learning. In terms of focus groups, when we carried out the focus groups, 2/3 had never heard of PrEP. They were very skeptical about PrEP and its effectiveness, the fact that it's on a trial and are we guinea pigs, there was all that hoo-ha. There was lack of PrEP messaging directed to Black African communities, and therefore they felt this was not something for them. There was a lot of stigmatizing messages associated with PrEP because it wasn't tailored to the Black community, and a need for a targeted campaign endorsed by Black African or Black ethnic minority celebrities, influencers, and community leaders. So with that, we went on to produce resources that were resembling the target group we're trying to engage with. We used language that resonates with this group, but also still a lot of feedback we received was the need to demystify PrEP. There were a lot of misconceptions. There was a need to address the lack of basic HIV knowledge in this target group, a need to normalize PrEP just like we normalized condoms, a need to address issues around accessibility of PrEP, especially for the Black African community. There's a lot of fear around accessing it from sexual health clinics. Who knows going to get my details? Who's going to see me there? So these are some of the things that we need to look at, are the options we are providing for PrEP access appropriate for all communities. That's food for thought. Need to address stigma associated with using PrEP. The fact that we told when we were doing the awareness that PrEP actually contains a drug to do with HIV. Some of its packaging looks like HIV medication. That is a barrier for some people to be seen with that medication. They'll be presumed to be HIV positive and they don't want to be in that situation. So there's a need to address that. And a need to establish a network of PrEP, Black African PrEP user champions, so that this can be shared in different settings and gain confidence use of PrEP. In conclusion, we have, as the project with the partners we have, been able to demonstrate that Black African communities, community-based organizations play a key role in raising PrEP awareness in this community. Community-based organizations have the skill and experience in developing culturally and linguistically appropriate PrEP campaigns and material that can be accessed by a diverse community. We've been able to produce innovative and digital PrEP content and material, which resonates with this community, and it's been embraced. The campaign has been embraced. And with an increase in PrEP awareness and uptake among this community, there's a possibility to see a reduction in new HIV infections. Then just to come up with the resources, I don't know how clear that will be, but coming back to when I said the 4 key messages, one was how prepped, and we played on the word prepared. How are you prepared to have a healthy sex life? We have with PrEP, no worries. With PrEP, no wahala. With PrEP, hakuna matata. And we did put what PrEP is, and because that was also key to identify that PrEP is a pill that can stop you from contracting HIV. It is also confidential, personal, and yet effective with no fuss. Those were some of the key messages. Something that also came up was key lines. Are you HIV negative? Are you having unprotected sex? Or are you having sex without a condom? Have you thought of taking PrEP? And these are probing questions that we thought were important to speak to each individual's behavior. This is just a mood board for the video we created. And again, starting by saying what PrEP is, and key messages that came out of our co-production focus groups. PrEP helps you overcome the stigma and embarrassment associated with using a condom. The fact that you don't have to go to a pharmacy to buy the condom, to the whole social embarrassment of trying to get the condom, pay for it, take it, and then go to negotiate using it. PrEP is reliable, effective, empowering, and above all gives you a peace of mind. It's discreet, and you don't need to tell anybody you're on PrEP. If you don't know your partner's status, why not think of using PrEP? If you don't like using condoms, why not think of using PrEP? Those were key messages that came out in the video we produced. Unfortunately, it can't play, but you can access this video and all these resources on our website. It's prepandprejudice.org.uk, and they're downloadable as well, so feel free to access that. Thank you very much.
Judy, that was fantastic. Thank you. And I love the campaign, and I so like the idea of a PrEP jingle to play on the radio. I'm really jealous I didn't think of that. That's marvellous. So could I invite Haru Mujangwa to the stage, please? He's going to be talking about PrEP from a personal perspective. Is that you, Haru? Yes. Let me get you up.
Hi guys. Hi, sorry, my voice is a bit funny, but again, it's not coronavirus, I have checked. So my name is Haru, and I'm here to share my story with you. Thank you for allowing me the opportunity to stand here and talk to you guys. I think it's a really important message that we need to get out there for all people to hear. I will briefly go into my discussion around like how I saw my own risk perception, the strategies for spreading this message, and how to increase demand for people who look like me, and hopefully how to start engaging behavior change around those types of people as well. And lastly, I have some entry points which I was asked to add in by my workplace. Working for Health Innovation, they wanted me to also explore how to do this. I will not go deep into this because everyone knows what PrEP is. You guys have way more knowledge than I do in terms of this discussion. But what PrEP means for me is it's part of a comprehensive way of preventing HIV. I think it's really important to distinguish that whilst condoms are for STIs, PrEP will focus towards HIV. And when we make those distinctions, it allows other people to not feel like we're trying to replace condoms. And that is the feedback I get quite a lot of, like, are you trying to remove condoms out of this? So being here, I want to basically discuss how I came through this journey. The person who helped me understand my risk was my grandmother. Although all the facts and all the statistics were there, my grandmother was really strong and silent and quiet, and she had 11 children. So she wanted to ensure all of her 4 girls were educated before they got married. And she made it just like basic rule, no one's leaving this house until we got married. This allowed my mother to offer me more social mobility, more access to education, and being able to move to England. From Zimbabwe, where I was born at the age of 12. At that point, I thought, oh, we're going to be safe. I've been promised this perfect life where everything's going to be fine, only to find out that the risks of catching HIV were still there. And as I became a teenager, it became much more real what risks I was facing. My grandmother had one daughter named Ludna, who was my auntie, and she died at the age of 37 from HIV. I think watching this strong, silent woman's face and demeanor change and suddenly become vulnerable kind of like hit the whole family quite hard, and everyone started thinking of ways to reducing the chances of HIV affecting our family, but it did affect almost every single Zimbabwean family during that time. So I was not alone in my story. But her reaction towards it just basically said to us, like, I'm not going to bury any one of you anymore, so you need to do whatever you need to do to ensure that this doesn't happen. And this encouraged me to make the changes within my life to stop this from happening. So I want to go through my story through Majorowitz, a behavioral change psychologist, and he talks about how we learn our behaviors. The information around what my risks were just plain out there, obvious. Everywhere in Zimbabwe, there'll be posters. When I moved to England, there was much less so, and I would have conversations with children at school who would say, oh, I thought HIV was just something African girls got. I didn't think it was something that was transmittable between us. They were 15, so I don't think anyone has that much sexual health knowledge at this age. But I already had an aroused fear of the disease from growing up in Zimbabwe. I understood my own personal vulnerabilities towards it, but the most important thing was raising my self-efficacy to believing that if I changed my health habits, I could then take more of my health into my own hands and being able to deal with it more effectively. This came not in the form of just me thinking I can do this, but a lot of other people supporting me. And I think it's really important to understand if you want any change to happen, a lot of people need support in order to allow that change to happen. The first person was when I went to a clinic at like 16. The clinicians were all very excited to hear that I was an African woman, so they brought out all the tests. They were like, we're going to do everything twice. We need to make sure. So they created like a very personal relationship with me. They knew me by name. They always sort of like would text me and just got very involved with my life. That developed trust. That also meant that they were able to like spend more time just making me aware of the things that I needed to know. And one of them mentioned PrEP, hence I am now here. The second thing was sort of having this person-centered approach. The fact that they actually knew my name was really, really important to me, because then I wasn't just another number or another statistic. I became a person. Looking for community leaders who also were doing what I wanted to do, but could encourage me to do it. First person I saw wearing a PrEP t-shirt was Black Coffee, who is a DJ from South Africa. And him actually saying that this happens was like amazing, because I was like, yay, there's someone else who understands the risks that we're under. MTV Sugar started mentioning a lot about PrEP during an episode that I was watching, so they became faces that looked like mine, talking about the issues that I was facing. But like everything else, my results or my outcomes would have been physical, like side effects. I didn't really have any, so it was much easier for me to just continue. But the social reactions, so if I was going to see my mom, I would ensure like I would put my pills into a plastic bag so they wouldn't shake or make a sound. So she wouldn't ask me, what's that in your bag? Let me see what you're doing. So there was like a bit of backlash on like how would my family respond, how would my friends think of it. Eventually, I just kind of realized I actually had more friends who were more supportive of it than the ones who were not supportive of it. But my personal self-evaluation was that I'm protecting my life and making myself feel better. So that's what's most important here, and investing in my own health. I personally think my pathway into this has kind of been very easy. This is, again, because I come from quite a privileged background. My parents were very well educated. I moved to England. And I went to university. I understood all the facts that were sort of placed in front of me. So my path, I don't think, really mirrors a lot of people's paths. But the pathway is having this knowledge and risks of my health. This perceived self-efficacy of my health is within my own hands, which is really, really important, because a lot of people don't have that. A lot of people still have to negotiate for condom use and a lot of other things which they can't face. My having health goals and strategies to facing them, that was made super easy by all the clinicians who were supportive, who were helping me develop these goals, and perceived facilitators, because I went out looking for these people. I went looking for MTV Sugar. I could find facilitators who matched what I wanted to do. The social and systemic structural impediments are probably where we all have to work quite hard to ensuring that other people who don't have such a clear path are able to face and make the changes that they want in their life. So I asked a few of my friends. I sent out a survey in the spirit of research. And these were some of the results that I got back. I sent it to, I think, about 100 people, and 50 of them just didn't know about PrEP. They were like, what are you talking about? I think 61 didn't believe that it would work. So I'm there telling them it does work, but they still just were like, no, something's gonna go wrong for you. And people felt like it was encouraging more people to have sex than to abstain from sex, but none of them are virgins, so I don't understand why they think this is even a thought process. And having the people who didn't have support networks were probably far more, which kind of hit me hard, the fact that like they couldn't really talk with their partners because it meant their partners thought they would be cheating, and they couldn't go to family members, or their biggest fear was their families finding out, like me. So creating this support network, either through peers or other people, is probably most important to ensuring people had the support to make these decisions. Some people felt the consequences would be that they would be judged. There was just a discomfort to do with anything associated with HIV. It meant that they were going to start having unprotected sex. So creating a behavior change when you don't have all of these things in place just makes it a lot more difficult. And to end is my entry points that I think would make it a lot easier to reach more people with PrEP, like targeted, personalized. Like so much of what I've heard today, all of this is being done, so I would literally not waste your time. But interactive technologies, sort of decentralizing how PrEP is offered, so it's not just going to one system, ensuring that medical staff are happy enough to actually talk to someone about PrEP when they first see them, and following like television shows which have characters going through similar things is really helpful. Thank you guys for listening to me.
So can I invite everyone back on the stage again? So I know you just ran off, Harry. Harry, thanks, that was great. I always think kind of personal testimony is really powerful. So we've got about 10 minutes for questions, 5 minutes for questions, 7 minutes for questions. So I can sit down. No, is this working? Is this working? Can you hear me? Marvellous. So actually, I've got a question I wanted to start with while the audience, if you've got a question, put your hand up so they can get the microphone to you. So I thank you for all these talks. I thought they were fantastic. I guess the question that always comes into my head, and kind of Judy touched on it briefly, and Amelia's talked about it. So Amelia was saying that only 4% of people on the impact study are women, and only half of the places have been used. And this is with the kind of MSM places continually getting used and redone. And obviously, it takes two people to have sex. And I think what is often, I kind of the voice I always think is missing are the heterosexual BAME men. And I'm kind of wondering, because if only 4% of them in this trial are women, I think it's a tiny handful of heterosexual BAME men. And I was wondering if anyone has any clever ideas or thoughts about how we engage that community. I'm going to give it to you, Judy, but give it to everybody else.
I think I'll start by even clarifying the 4% is men and other groups. So so the women is less than 4% because 4% is men and others. So that means the BEM men are in that, but that's just 4%. We had a whole discussion about this when we launched our campaign, and the fact that men have a power. They can utilize, the Black African men especially, to take control of HIV prevention. A lot of times we, heterosexual women, have sex with men. We're not having sex with ourselves. So it's important that they take initiative. But there are a lot of ways I think we have to explore in terms of how we engage men. Peer-to-peer conversations we feel is very key. We tried this in a pub in the middle of London, I won't say where, but Zambian-orientated pub, and we found that having discussions with them on a Friday night was very effective. They're bound to listen to you. It's a happy atmosphere, mainly a sexualized atmosphere, and talking to them. Having, I think, also PrEP users who are openly able to talk about their experience will alleviate a lot of skepticism. So I think things like that would work. We've also looked at using theatre in education, again targeted to men groups, and openly discussing sex in men's settings and what fears they have, what experiences they're looking for, and how to do that safely would be helpful. Thank you.
Fantastic, thank you. Have we got any questions from the audience?
Hi, hello, my name's Edem. I work for NAS, but I'm also part of a collective called Decolonized Contraception. And I just quickly wanted to ask if people on the panel have thoughts around this. I find that like some of my main challenges, and I've been working on and off in the sector for about 8 years, especially with Black African communities around sexual health and HIV prevention is a lot of the conspiracy theories that people have around it that are very, very real, but also in my work with decolonized contraception, a lot of the historical experiences that our community has had in terms of sexual and reproductive health with, unfortunately, a lot of time in the programs that we do, we don't really have time to address, or they're not really built in a certain way. Do you find that that's proving to be a barrier and a challenge in some of the work you do? Do you come across it quite often? Because I know I do, and I just wondered if you wanted to share how are some of the ways that you overcome that.
So who wants to answer that? So do you want to say something?
I will try and respond to the conspiracy theories, as you call them, and historical past. I think acknowledging it is definitely necessary in order to start the conversation. Framing any discussion around what you know the person finds important is going to help you just reach to the goal. Especially in Africa still, there's a lot of substandard drugs that are still coming into sub-Saharan Africa, speaking specifically. So if you acknowledge that and you make it aware that yes, they are still things that are going wrong, but we are trying to do this right, and we are trying to check that these drugs are coming from the right places, then you are acknowledging a worry that they have by framing it around what they've said.
Okay, have we got any other questions? Anybody else? We've got a couple of minutes left. I want to try and get as many in as possible. We have a question at the front.
Mark Lewis from THT. I want to ask a question on, yes, we're doing well in PrEP uptake and lowering transmissions in big cities. So how do we increase uptake of those men and women in rural communities who don't know about PrEP? And if we are going to hit the 2030 target, it's those pockets that we need to reach out now to and educate about PrEP. So how do we do that?
Greg, do you want to give that a go? Because I guess the internet's going to be part of that answer, isn't it?
Well, thank you, Mark, for the question. Haru, you deal with some stuff like this as well back home. So I'll pass the mic to you in a minute. But I think overcoming that barrier of being in a rural setting, is quite a lot of our stuff has moved online, but we also need to be integrating. So we can find people who are vulnerable to HIV. We kind of generally know what the indicators are and which type of people they are. So I would always suggest you can't de-ruralize somewhere, but you can certainly tap into networks and other service provision that is already there and servicing the need, some other part of that person's need. So to me, you need to integrate and you need to be innovative. So our PrEP at home model, which we're exploring at the minute, is a full e-service with postal and text, that's it. So there are options, but we probably, I'm going to pass it to you.
So I've been trying to reach the rural community in Zimbabwe, and one of the only ways we found is radio. So spreading the message through radio, because a lot of them will listen to radio, and trying to do the task shifting as well. So not just utilizing the already existing services, but also trying to find people who do something that is to do, like the miners and the people who move agriculture, they're going in and out quite often. One of the issues we've had is delivering the drugs to people who are even more remote. So trying to find the mid space of getting the drugs to them is really hard.
So just a quick word. I think all community have their gatekeepers. So even in London, there are still this kind of pocket exists. You go to these small communities that no one actually heard about PrEP. That's why in our research we do find there's very low sort of awareness of PrEP among men. But I think there's different way to access them. I think Jodi's work also tries to engage health staff, like people who might not be users themselves, but they might not identify themselves as users of PrEP, or they don't know about PrEP. But then there are also health workers, and then there are other sort of a platform of staff. If they are equipped with that level of knowledge, they should be able to actually talk to their service users. I think that is also a way to go for.
Brilliant. So that's the end of the session. I'm getting a cabot from the back of the room. So I thought that was been a brilliant session. Thank you to all our speakers. And I think there's a session in here in a bit. So if you're moving somewhere else, move now, and everyone else can come in so that we start on time. Thank you very much. Thanks very much, Greg. Thank you. You too. Thank you. I so want to know the
well done for staying to the last session of the day. There's more stuff after this, but the last group. So this session is going to be around sexually transmitted infections and sexual health, and we've got 5 different presentations for you. The first speaker is my colleague from the GMI Partnership, Alyssa Ferry, who's behind me, and she's going to talk to you about STI diagnosis amongst asymptomatic men who have sex with men in community testing services. I will just wait till everyone sits down. Okay.
All right. Can everyone hear me? Yes? Okay. Thank you very much, Karen. So as Karen mentioned, I'm going to be talking about STI diagnoses among asymptomatic MSM that we've encountered through our community-based testing service across London. So if anyone was here previously for Dee's presentations, she introduced a little bit about the GMI partnership. For those of you who weren't here, GMI is a partnership of 3 London-based voluntary sector HIV charities, Spectra, Positive East, and Metro. This is a little bit about what we've done over the last 11 years of our partnership. I'm going to be focusing on the integration of sexual health screening within our HIV testing service. So this was introduced in January 2016, and since then we've conducted 962 sexual health screenings. I'm going to present some data from 2019, because in the past couple of years we've kind of ramped up the provision of this service and offered it more routinely. So just a little bit about the GMI outreach model that we use. We provide point-of-care testing for HIV in a wide range of London venues. That includes bars, clubs, saunas, and others, primarily with men who have sex with men. It's a peer-led model, so we use a combination of staff and trained volunteers to provide both the outreach and the testing service itself. Since 2016, we've partnered with Bart's NHS Health Trust to have an additional offer of sexual health screening. So basically, we use the self-screening kits that Bart's would normally use for any asymptomatic London resident. We basically support clients in taking their blood. We do know that that is a barrier to some people actually pricking their own finger. The client themselves will take the samples, the swabs, and the urine samples, and then we send the kit off to Bart's. And all of the results are handled then by Bart's, as they would for their regular self-sampling kits. Within our kit, because we provide point-of-care HIV testing, our sexual health screenings include syphilis, hepatitis B and C, gonorrhea, and chlamydia. Those are at 3 sites for gonorrhea and chlamydia. It allows us to expand our sexual health offer to all of the people that we encounter on outreach, which includes people who are living with HIV, and occasionally sometimes people who are on PrEP as well. We do have a clinical oversight arrangement with Bart's NHS Trust. We are not commissioned to provide the sexual health screenings themselves, but we do feel that it does add value to the service that we provide. And our model is one that evolves. We're always ready to respond to a changing environment. So a little bit about our findings, 2019 data. So in 2019, we provided 540 people with a sexual health screen. Within each sexual health screen, there are 9 tests that are provided. So the 540, that represents about 33% of the people that we tested for HIV in that same period. This is just a little summary of the results that we've seen. So some of our positivity and reactivity rates for the various STIs. In total, during 2019, we found 191 STI cases. So just a little bit of a summary. Syphilis was 72 cases. Chlamydia at all sites was 50. Gonorrhea, 30 cases. Hepatitis C, 7. And hepatitis B, 32. So these 191 STIs were detected among 152 individuals. So 120 individuals had one STI or one site of infection. 25 individuals had 2, STIs or the same STI but at various sites. And 7 people had 3 STIs or an STI at 3 different sites. So that means that of the 540 people that we tested who were asymptomatic MSM, 152 of them tested positive or reactive for at least 1 STI, which is 28% positivity reactivity rate, which we're very proud of, and we think that it's quite impressive that these are asymptomatic individuals. One limitation is that the syphilis and hepatitis C tests that are done through these kits are antibody, so it's not possible to differentiate between historical and new infections. So a more conservative estimate, if we discount all the people who were diagnosed with syphilis only, hepatitis C only, or combined syphilis hepatitis C only, we would still have 97 unique individuals who had tested positive or reactive for at least 1 STI, which is still 18% of the asymptomatic MSM that we did test for STIs through our project. This is just a little bit of a summary around the common co-infections that we saw. So for the, I think, 32 people that we saw that had more than 1 STI, I've just differentiated syphilis and the other bacterial STIs because of the caveat around the syphilis. But most commonly, we would see 15 people had syphilis plus at least 1 bacterial STI, chlamydia or gonorrhea. 8 people had a co-infection of syphilis and hepatitis, B or C. 6 people had more than 1 bacterial STI or more than 1 site of infection for a bacterial STI. And so on. So I've just, to conclude, just to do a small mention around the benefits, as we see it, of combining HIV and STI testing in community settings. It allows us to offer sexual health screenings in an opportunistic way, for people to access it in an opportunistic way to asymptomatic individuals. We are finding high rates of STIs. It allows us to, rapidly engage with clients. They're able to then rapidly engage with treatment, which ultimately prevents onward transmission of STIs. It allows us to offer a more holistic offer, which has proven very popular both with clients and the venues that we work with. Our model relies very heavily on collaboration with venues and commercial venues. And anecdotally, a lot of these venues have mentioned that they're very, very proud of this additional offer of being able to provide a full sexual health screen for their customers. It also allows us to engage with people who are living with HIV who might wish to get a sexual health screen in between the regular appointments with their consultant. And we do see an increasing number of people who are using PrEP who do come to us for our service. We will always let them know that they can access sexual health services and about creatinine testing, but we won't refuse someone a test. We will just provide the education around further testing. Our testing model, both for HIV and STIs, is very mobile. It allows us to go where people are and really go, integrate STI and HIV testing into people's lives, whether their lives are at saunas or at bars. And it also allows us a high level of flexibility in terms of reacting. If we know that there's an outbreak, an increase in STI rates in certain subgroups or certain areas, it allows us very good flexibility in terms of addressing that. And we do also help in some ways to filter out asymptomatic clients. Clinics, especially in London, I'm not sure about the rest of the country, but sometimes can struggle to see all of the asymptomatic people that come to them for an STI testing. Oftentimes people will receive a self-sampling kit, and what we've seen is a lot of people actually struggle to take the bloods. So the e-service is fantastic for people who are comfortable using it. Sexual health services are fantastic for people who are comfortable using it, but we provide an alternative for people who somehow fall between the cracks. Some of our limitations, finally, providing the full sexual health screen does increase our kind of time per intervention. We're not just doing a finger prick test and giving a result after 5 minutes. We do have a bit more of a discussion around STI risk as well. and it does just physically take a bit more time to take the additional samples. The sexual health screening portion of our work is not actually commissioned, but we do feel very strongly that it adds value to the clients that we see. The way that it's funded is the same way that the self-sampling kits are funded. So the sexual health clinic will look at the postcode, and then there's a mechanism that we're not involved with around recharging the local authorities back based on the residents that, for whom the kits, or when they get the kits, there's a postcode attached to it, and then the clinic will invoice that local authority for the test. As I mentioned before, we do antibody tests for syphilis and hepatitis C, so we're not able to distinguish between a new and a historical infection. And we are somehow site limited because there's a urine sample or swabs. We are limited to providing the sexual health screen to venues that do have a toilet. And the other limitation is that the data that we get back from the NHS doesn't allow us to disaggregate by ethnicity or risk profile or anything like that. So we just get kind of an anonymized list of the people that we've tested and the results. And so finally, just a massive thank you to everyone who's been involved. The GMI outreach team that, day in and day out go to these venues and provide this service. The Barts NHS Trust and the Ambrose King Center team, who do a lot of the results notification and do a lot of extra work to make sure that this service is available. Big thank you to our funders, the people that do commission us to provide HIV testing in the community and sexual health advice, and to all the amazing volunteers that also contribute to this piece of work. So thank you.
Thank you very much, Alyssa. Alyssa Ferry from GMI Partnership, thank you. So the next speaker we've got for you is Phil Samba from Prepster. Phil, do you want to come up? And Phil's going to be talking about increasing STI e-testing uptake amongst Black queer men. Can you see it there?
Oh.
Oh. Okay.
Do we need to inject it?
Yeah.
Or you need to inject it. Thanks. Hello, everyone. I always have to adjust this. Today, I'm going to be talking about increasing STI and HIV testing amongst Black queer men. But I'm also going to be talking about other demographics. And when we're talking about men in general, and I guess you'll see why. So Black queer men typically have poorer sexual health. The uptake of sexual health services tends to be lower than their white counterparts. And research shows that research indicates that perceptions of racism and homophobia from service providers. E-services have the potential to remove barriers, yet uptake of e-service sexual health London by queer men of color tends to be a bit lower. So what can we do about this? So days before UK Black Pride, which is the biggest celebration, Europe's biggest celebration for queer people of color, we shared these images on our social media across Facebook, Instagram, and Twitter. And basically, we offered the Sexual Health London e-service with a unique link so that we're able to track the data. Health promotion in sexual health has become a bit sanitized, so it's not really common to see, I guess, queer men of color like without their clothes on or in any sort of I guess. My point is, sexual health campaigns should be more sexual, I guess. We need more specifically targeted campaigns made by us and for us, utilizing our voices and our experiences to reach people that are like us. Also, both the models that were in this, they shared it to their personal social network. So we think that that might be key as well in success. Outreach in clubs is still very important. However, I know from firsthand, from experiences and conversations with friends that a lot of black men are tired of being offered condoms when it comes to being on a night out, because that's not necessarily what they're there for. What we did with this particular intervention is we took this image, we put it on our social media, but we also plastered it all over UK Black Pride. The second picture is actually a urinal. It's a four-way urinal. We posted it all over the toilets, all over the back, wherever there was food, across the whole thing. And basically, the models in this also shared it on their personal networks. I shared it on mine, and I noticed some really interesting stuff with the data. If you follow me on Twitter, you know that I tweet a lot of nonsense a lot of the time. I tweet a lot of all different kinds of things, and I use Twitter to basically interact with my community and to I guess, raise awareness of PrEP and of testing and do all different kinds of things. But this is my social media versus the social media of PrEPster. Mine is on the left. And although there's less impressions, there's like much higher engagement. The link clicks are actually not too far off as well. Okay, here's the boring part. Basically, Sexual Health London collected data from 6 weeks before the intervention versus 6 weeks after. And the findings are quite interesting. So in Black Caribbean men, wait, there's one more bit. Basically, we did it from a range of who the people that were getting the test were kind of saying who they were having sex with. So the categories were men, both other and women. For Black Caribbean men, there was a 35.4% increase in men who said they had sex with men, 101.4% in men that said both. No uptake in other, and 3.5% increase in women, with the total increase being 10.8%. In Black Africans, there was an increase of 13% in men who have sex with men, no change in both, but interestingly, there was a 750% increase in those that selected other. And in men who have sex with women, it was 12.1%, with a total increase of 12.3%. In those of other background, there was a 108% increase in men, 33.3% decrease in both, no change in other, and 1.2% decrease in women, but still a total increase of 7.8%. In Black African and white communities, there was a 10% increase in men, 18.2% decrease in both, no uptake in other, and 1.4% increase in women, totaling 1.5% increase. In Black Caribbean and white men, there was, in men, a 15.1% increase, 19.7% in both, 550% in other, and 5.4% in women, with a total increase of 6.9%. Compared that to the findings that we had within white British men, it was a 6.1% increase in men, 1.9% increase in both, 6.8% in other, and 6.1% in women, with a total increase of 5.8%. So in other men of color, there was, in Bangladeshi men, there was a 4.5% decrease in men, 42.9% increase in both, and no change in other, with 8.3% increase leading in women, with a total increase of 8%. In Indian men, there was a 6.6% decrease in men, 6.5% uptake in other, no change in other, and where is it? So I've done this wrong. 31% increase in women, with a total increase of 18.7%. In other Asian background, there was a decrease of 17.6%, an increase in 67.4% in both, no change in other, and 24.1% in women. With Asian and white men, there was a 10.4% increase in men, 233.3% in both, no change in other, and 15.7% increase in women. With other ethnic group, there was a 1.5% increase in men, 18.6% decrease in both, no change in other, and an increase of 9.4% in women. The results are quite strange, and we feel like we can't directly explain how the increase came about, but basically there was a much higher increase considering the intervention that we did. Going forward, we're actually we're redeveloping this intervention through sex on premises events targeted primarily at Black queer men. I think that, like I said earlier, I think we should be using a lot more racier images, and we should have men of color involved in developing the campaigns, not just being within them. Personal social networks may be vital into increasing testing, and there was a really great increase in Caribbean men overall. The scope to do more for Chinese men, as uptake actually went down by 1.6%, and men from other mixed backgrounds also went down by 1.7%. The last thing I have to say is that the last two things are the national reporting arrangements are not great for Latinx communities, which are getting high rates of HIV, but it's not down to SHL, as they're using the same system as clinics. And also, with such a high percentage of Black Africans choosing other, we suspect that there are many men who are having sex with men who don't identify as men who have sex with men, but connect with the imagery. As a Black African man myself, I kind of understand the difficulties of what it can be like to kind of come out or to express that to your family, or like the kind of pressures of culture or religion that has an effect on that. So, yeah, thank you.
Thanks, Phil. Phil Samba from Prepster. Thanks very much. So our next speakers are Wellington Moyo and Pat McCusker. There we are. And they're going to present about different community models to reach key populations in the north of England. Okay, how do we get out of this? Right, can you see your presentation there? Excellent.
Oh, how'd you do it? Is it that one? Yeah. Cool. Hi, I'm Pat. I'm the local services coordinator of Wakefield Mesmac. And I'm here to talk to you a little bit about testing in an initial accommodation centre. Background. So initial accommodation centres, there's like a network of maybe 7 of them across the country, I think. There's one in London, but the majority of them are in the north and in the Midlands. And they are places where people come when they've just arrived into the UK before they're dispersed out to NAS accommodation. So in Wakefield, people are there for like 2 weeks at a minimum, but sometimes if there's problems finding NAS accommodation, they can be there for like a month or more. It's not like a super nice place. It's basically like food and a bed. There's like minimal access to primary care because you can't get a GP. There is a nurse that works there, but she's not commissioned to do HIV testing. In fact, the health interventions she can do are really limited. So we go in and do testing. In the cohort, like rates of unprotected sex are high, rates of sexual violence, non-volitional sex are high. There's lots of women who've had experience of sex work, and lots of women who've had experience of trafficking on their way to the UK are there as well. And there's decreasing immigration from super high prevalence backgrounds. So immigration from sub-Saharan Africa has decreased, as we know, but there are still high numbers of African people there, just not as high as there once were in 2007. So yeah, there's there's 300 beds for newly arrived asylum seekers, and they stay there before they're dispersed. Okay. So how do I do it? Methods. So I love this work, and I think it's really important that we talk about it. And I love it because it feels like a resistance to the hostile environment for a lot of the people that we see. And oftentimes it feels like the only point of welcome that particularly LGBT asylum seekers who do a ton of work have when they first arrive to the UK. So if you've got an initial accommodation centre in your area, I'm a big evangelist for working in them. So what we do, we offer weekly testing session, and we do HIV and syphilis point of care tests. We work in partnership with the local asylum seeker refugee organisations, offering a weekly cafe, and there are English lessons, legal advice, there's a clothes bank which is really popular, and we offer point of care testing. Now we don't offer chlamydia and gonorrhea screening, and the reasons for that are super annoying. So basically, because they might be dispersed really quickly, the sexual health service, I hope none of them are here and are going to get annoyed with me, but the sexual health service aren't super up for processing their result because they might be dispersed quick, and they want that linkage into care. So it's a bit annoying that we can't do it, and I wish we could, but we can't, but there you go. And we offer a monthly peer-led drop-in for LGBT asylum seekers and refugees. Okay, so the way that we identify LGBT asylum seekers and refugees within the centre is I've got this little rainbow that we've printed out, and on there's my number for a WhatsApp, and we give them to the nurse, and the nurse knows all the reasons why people are claiming. So we give them the rainbow WhatsApp, and then they text us, and we meet them and try and sort them out. Okay, so these may not seem like massive numbers to London types, but I thought they were good. So we tested 485 people. This is Q1 18-19 to Q1 19-20. Yeah. So we tested 485 people, 3 reactive HIV tests, 2 reactive syphilis. All of them linked to care, which was an achievement in itself. 30% of them were Black African. 12% disclosed they were gay, bi, or other MSM, lesbian or trans women. Okay. So that might not seem like loads of LGBT people, but it works out as one new LGBT asylum seeker a week. And I don't know if any of you have worked with LGBT asylum seekers, but one a week is a lot of work. They require a ton of advocacy and a ton of community development. Oftentimes they come in here with little to no knowledge of the gay scene or their legal rights, or any access to any advocacy in the UK, or knowledge of HIV is low, etc. So all of the reactives were women, despite that being a small amount of people who were tested. So it was about a quarter of the people that tested were women, but all of the reactives were Black African women. It's also a really good way of getting those people who are aware of their status but are not yet engaged in care quickly. 9 people were referred into our people living with HIV service from people aware of their status, and 3 are linked back to care in the UK. 52 LGBT asylum seekers supported, and we do outreach as well while we're there, and we've made 300 3,680 community contacts distributing lube, sexual health advice, and our little rainbow WhatsApp thing. Conclusion, providing community testing in initial accommodation centres is an effective means of reaching groups who are high risk for HIV infection and underserved by traditional sexual health services. The people there find it acceptable, and the uptake of testing is good. And like when I first started doing this, people were a bit annoyed about it, and they were saying stuff like, oh, well, now's not the time to test them, they're a bit too vulnerable, you know, they've got other things on their plate. And I thought that was a bit gatekeepery, to be honest, because people are experts in their own lives. They can say no, we're not forcing them to do it, but not making the offers a bit dumb. HIV prevention interventions work well, and they work well when they're delivered in partnership with asylum and refugee services. The outcome and experiences for LGBT asylum seekers has been very poor, and that group benefits a lot from extra peer support and other health and wellbeing interventions. And it's on to Wellington's thing. So those are my conclusions. I would say as well, like, it's really nice to be here kind of like celebrating doing this rather than justifying it, because I feel like I'm forever like asking for money to do this rather than being like, isn't this great? So thanks for having me.
Oh, thank you very much. Yes, my name is Wellington. I'm just going to talk to you today about the work which we are doing in Bradford. Our work, we work with commercial sex workers. Basically, how do we do it? First of all, we started by finding each other, trying to identify the organizations that support this group of people. So what we did was we managed to find that there is a project which is known as Lotus Project, which is working under the Bridge Project, which supports the women who are working on the streets. And there is also local clinics as well in Bradford, which is the sexual health clinics. So we joined hands together in trying to give this group of people a holistic support. So basically, how do we do it? We do have some drop-in sessions whereby we advertise these sessions online and we invite those who are willing to come and engage us privately. And also, we do have a virtual outreach. We try to reach the links at which they are advertising their services, especially the adult links. And so far, our regular support is targeted. We have 76 women who are registered, or in fact, who have got cases who are within our caseload. So what we mean is that these women, they are working in the streets of Bradford, and we do have a team of outreach workers who go from time to visit them as they are doing their work in the streets. And we also have 20 who we are still trying to establish some relationships, because working with these women is not an easy thing, because you need to take time really to develop some kind of trust. So we are still trying to develop some relationships with them. So that's why we say it's pre-caseload. And we also have 23 men who are advertising their services online on Viva Street, and we also have 2 transgender as well. So out of the 3 organizations that are working in this kind of outreach, this activity, we have a combined number of 11 staff workers who are trying to support this group of people. Who are they? Who are these commercial sex workers? This is a group which comprises of women. And most of these women, they come from different backgrounds in Bradford. And also remember that Bradford is one of those areas in the UK with low cost housing. So I think many people are driven to go and live in Bradford because of low rentals and other things. So we do have a wide range of women who are selling sex in the streets in Bradford. And the reason behind that is drugs, because some of them, they are trying to finance their drug habits. And also one of the things that has been identified is that these women are highly vulnerable. Some of them, they are being pushed. There are some people who are using them to generate some income. So, and we also have MSM. These are men selling sex with men, and mainly these ones, we reach them through the online links, especially the adult links. And we also have a team of workers who are trying to reach them on other links like Grindr as well. This is a mixed group of people as well. It's gay, and there are some also who are bisexual. There are quite a good number of people, and also from different backgrounds. We also have trans as well. We also reach them on online outreach, and this trans group of people, they are in varying stages of transition. Some, they have come out that they are trans, and some of them, really, they haven't come out, but we know that they are trans, so we try to give them support as well. How do we do it? Since there are 3 organizations, we cannot be duplicating things, so some people should be focusing on certain things. Lotus Project is the one which is mainly dealing with the ladies on the streets. So they go out there after hours, maybe from 7 p.m. up to around midnight, trying to reach them out, speaking to them. And they also do more than that as well, because most of these women, they are also injecting drug users. They also do some needle exchange and also give them some condoms. Within our service, Yorkshire MESMAC, we provide a safer space for them where they can come and get tested, and we also give them some sexual health advice. And Locala clinics, they give them the whole STI screening. So this is how these tripartite organizations work. So far, these are the results of what we have been doing for the past 18 months. Yes. Yes, increase in PEP and PrEP uptake. In Bradford, we are recording an increase of people who are coming in asking for these services. And also, we have also seen a kind, though of course it's a national trend, but looking at our figures as well in Bradford, there is a great reduction really of people who are diagnosed of STIs and HIV. So we believe that it is a result of that combined effort by these services. As you can see in numbers, we have got a total of 76, 20, and 44 men. So, and also, I think, yes. In conclusion, what we have just come to realize over the work that we have been doing collectively, and also vis-a-vis the commercial sex workers, they are the only group at the moment which are recording an increase in STIs. So we come to learn that, like, sometimes maybe the future interventions on STI, including HIV, instead of targeting maybe certain groups of people like MSM or African communities, but if we target the behaviors, maybe we can help to change things quickly. And also, one other thing that we have come to realize as well is that marginalized communities engage better in better health outcomes. And interventions targeting behaviors like what I said, they seem to really, really achieve more, because now when we are talking about commercial sex workers, we are not talking of a particular group of people from a different background, but it's a mixed group of people. So basically, this is the work that we are doing in Bradford in terms of supporting the commercial sex workers. And thank you so much for listening.
Thank you very much, Wellington and Pat. 2 really super interesting presentations there from Yorkshire MESMAC. So the next, Steve Madden is our next speaker from Wiltshire Council, and he's going to be talking to us about sexual health promotion in the over 50s. Let me just escape out of this one.
Should be the last one. It should already be open, actually.
Oh, you're fine. Is that it? Yes.
There we go. I know we're very close to a coffee break. I will keep this very brief. If there is an award today for the shortest presentation, I believe I should have it. I have 4 slides in the video, and that is it. We're going to go with real efficiency. So my name's Steve Madden. I'm one of the public health consultants. I'm here from Wiltshire Council. I'm representing not only Wiltshire, but also Swindon and Bath and North East Somerset. Really, I'm an imposter here today because all the work that I'm about to present to you hasn't been done by me. It's been done by Age UK Wiltshire. All it had from me as a commissioner in a local authority was to say, that sounds like a good idea, so you can get some money to do it because I don't have any. And they managed to get some, which is fantastic. Age UK Wiltshire couldn't be with us this afternoon. I kind of laughed to myself as I walked here from the train station because Age UK national office is like round the corner. So they could have given me someone, but there we go. Okay, so to give you a bit of flavour, if you may have heard of Wiltshire, we're a relatively large county of about 500,000 people. We made the news about 2 years ago, so I do not want to talk about Russians or poisoning today. And actually, it's quite nice to be here not talking about Novichok, so exciting to be let out of the office. As you can see from our data there, across Baines, which is Bath and North East Somerset, Swindon and Wiltshire, our HIV prevalence isn't kind of surprisingly high. As you would expect, we're a big rural area. It takes us about 2 hours to drive up and down and side to side. Our population is generally elderly and quite middle class, as you'd probably expect from the south. But for us, we did recognize that we are seeing this increase in trend in HIV diagnosis in older people. And late diagnosis is a real concern for us. So we've noticed this around sexual health in general, but we felt that actually this is something we needed to focus on, especially as we look in Swindon, which is almost double that of the other counties. I put there as a kind of an indicator to show you that we're well below what the HIV prevalence is in England. But for us, we've doubled our prevalence over the last 5 years, so it is becoming a bit of a concern for us. To give you a bit more context, 55% of our diagnosis is in the over 35s, but a further 30% of those are in the over 50s, so it is recognizing that there's an issue there. You're getting a very pared down version of our sexual health overview. I've had to cut out all my pictures of the Golden Girls, which is really annoying, but I can provide that for a fee. Majority of those with HIV in our county are male, and primary transmission route is men that have sex with men. And not unsurprising again for our county, over 75% of those with HIV are white British. The concern for us, as I said, is very much around late diagnosis, because we know that late diagnosis ranges from about 40% in Bath and North East Somerset up to 64% in Swindon. And again, when we compare that to actually those in the over 50 bracket, that's a real concern for us around ensuring good quality life. So, the 3 local authorities, along with Age UK, put in a bid for money from the HIV Innovation Fund. Age UK felt that there was some work that they could do in promoting HIV awareness to the older population, but also how they could then promote it within the third sector overall. So they had these 2 ambitions, which was really around training and awareness to raise internally how to have different conversations. So Age UK as an organisation spend a lot of time talking to older people, and actually this was an opportunity to upskill staff so that they felt comfortable and confident in having sexual health and HIV related conversations. It was also about bringing the sexual health messages into any of the work that Age UK were doing. So again, it was a real opportunity to have a conversation or start conversations amongst elderly. Now, I say elderly, older people, middle youth, however you want to call them. I'm talking about people over 50, and I know that a lot of people over 50 will not class themselves as elderly or older. So I just want to put that out there. I'm not being ageist. The other element of the HIV campaign was for them to create a promotion campaign aimed at the over 50s, which is really about promoting risk, creating awareness around HIV, with the view that it would then help to reduce stigma overall and ultimately promote testing where appropriate. This is some examples of the campaign resources that they'd utilised. I think he looks like Jeremy Corbyn, but that was poo-pooed. They seem to which is ironic because the Wiltshire people picked this image, and we're a really blue county, so that's really strange for us. I'm not going to make any associations there. But again, what Age UK did is they worked really closely with the populations that they work with to develop these resources, to develop the language that they were using in these resources, and ultimately to pick the people that were going to become the face models of this campaign. I've got a short video to show you, which hopefully will work. If not, you'll have the link so you can go and see it. Age UK Wiltshire are really keen that if you think these resources are useful to you, then they are available to you. This is an Age UK Wiltshire campaign. It's not an Age UK national campaign, although they're very aware that they're doing it. So the resources are there to be utilised. Right, let's see if I can get the video to work, because that's basically half my presentation.
Travel, classic rock and roll, ballroom dancing. Yeah.
Great thing about being our age is that we can please ourselves.
Still no better? But that's over 2 weeks. You should check it out with a doctor. You really should.
I've been feeling a bit off colour recently, like I've got flu.
And have you had any other symptoms?
I've got an irritating rash in the groin area, and I had a sore throat and headache, and I've been sweating a lot at night.
And have you had any glands up anywhere?
My neck's felt swollen, and under my armpits.
And are you in a relationship at the moment?
I met Gina a few weeks back. We've become close.
Okay, and have you been using condoms?
Well, at my age, I didn't think that was something I needed to worry about.
There are a number of possibilities for your symptoms, so we need to do a range of blood tests just to try and work out what's going on. And because you are in a new relationship, I would suggest blood tests for both HIV and syphilis infection. Both of these are really treatable these days.
HIV? No, that can't be right. Jean's the only person I've been with since my wife died 5 years ago. People of our age? I didn't think HIV was a risk.
Well, you're right, it's not high risk, but it's definitely something that we need to consider. And there are really excellent treatments available now for HIV that keep people healthy and stop the virus from being passed to their sexual partners.
Jean hasn't shown any symptoms. And I doubt she's had many partners since her divorce.
Have you discussed your relationship history with Jean?
Not in any detail. I think her last relationship was a holiday romance. She likes to travel.
Travel?
She gets away to the sun in the winter, she says. Hates being cold.
Such a shock.
Well, it's really good that he's told you. And well done for coming in to see me today. It can't have been easy. Have you noticed any health problems recently?
Seen my GP several times over the past few months. He's treated me for chest infections, but they keep coming back. And I had shingles last year, which took weeks to clear.
Oh, well, we'll need to do a blood test so that we find out for certain. But if a diagnosis of HIV is confirmed, what we'll do is start you on specific treatment called antiretroviral therapy, and that's going to make your immune system stronger so you're no longer susceptible to infections. It will make you feel back to your old self again, and essentially it clears the virus from your blood so you're non-infectious.
What do I tell my friends?
It's absolutely nothing to be ashamed of. Although there's still no cure, people who take HIV treatment every day can lead a normal, healthy life, and the life expectancy is almost normal. Many people will not consider themselves to be at risk of HIV infection, particularly if they have been in a long-term relationship. But people of any age, gender, sexuality and ethnicity should be encouraged to test. The test is free and confidential, and having an HIV test could save your life. Additionally, if you have had any unexplained symptoms or unexplained blood test results, I would really encourage you to ask your doctor for a test. The best way to protect yourself from contracting HIV and other sexually transmitted infections is to use a condom with all new partners. For further individualised information, speak to your GP or local sexual health clinic.
Where's that slide gone? So I know it will haunt you, her saying, travel. Because every time, first time I watched it, didn't see it, and now every time I cringe because I know it's coming. It's a big thank you to Dr. Jess Daniels, who's our HIV consultant at Swindon General Hospital. So Jess was involved in a lot of the production of that, so we just wanted to make sure that the messaging was on point. And there's lots of things that we think could improve on that video, but actually on the whole we feel that it's a good thing, and actually if it just gets people talking, then that's fantastic. Right, so since we've launched this, which was back in September, October time, the initial evaluation I put up there for you. So budget wasn't huge for it. Just shy of 500,000 people were reached via local newspapers and magazines, because again, it's about where do we put the information when we're trying to target the right audiences. Maybe Facebook and Twitter isn't that useful, but actually we still managed to do over 70,000 via social media, which was really positive. We distributed just shy of 6,000 leaflets, had just under 1,500 hits to the campaign website. So they created a bespoke Age UK Wiltshire campaign website just for this campaign, which was brilliant. I don't know how they messaged people on their phones, but some people responded. Well, over 1,000 people responded. Not sure what their response was, but I'm sure that will come out in the final evaluation. 50 Age UK Wiltshire staff and volunteers were trained up to learn how to have these competent conversations around HIV with the people they work, which was really encouraging. It did receive radio attention, and actually we've recently just been on the television as well. So I put the link there again. I'm sure the slides will be shared, but we were on 2 TV programs, Victoria, Derbyshire, and what was the other one? I wrote it down because I know I forget it. Inside Out West, thank you, Nora. So again, it was showcasing sexual health in the over 50s overall, but actually again was showcasing a bit of the campaign as well. Campaign, essentially from Age UK's perspective, is just rolling on. They're very happy to share it, and some people, some of the local authorities in the southwest have picked it up, and some people in the Midlands and northeast have also picked it up. So again, it's just extending the option there to you. If you are interested, then do make contact, because they're very happy to share their resources. That video is already on YouTube, so if you search Risky Business, you'll find it. I'm sure it'd be a great Friday night one to show your friends. I think that's it from me. Thank you very much. And again, the contact details are there, so should you want further information, do get in contact. Thank you.
Thanks very much, Steve. So our final speaker is Patrick Hands from Yorkshire Mesmac. Right. Okay, possibly 2 speakers. Sorry, have I missed? Sorry, it's only got your name. You can introduce yourself. Talking about improving trans and non-binary sexual health. Let me just exit this one for you. Oh, I've lost the mouse. There it is. Okay, which one? That one. Oh, no, that's not it, is it?
That's no.
Okay. This one here.
One.
Yeah, that one?
Yeah, let's have a look at that. Fab.
How do you make that bigger? Do you know how to make
Yeah. Hi guys, can you hear me okay? Yeah, perfect. So my name's Paddy, I'm from Yorkshire Mesback in Leeds. I'm a local services coordinator there, and I'm here with my clinical colleague Maddie Crow, and we're going to talk about what we've done in Leeds to improve trans and non-binary sexual health. So I'll walk you through that partnership work, a little bit about background for it, and what we've developed. So just quickly some statistics from the National LGBT Survey in 2018. We recognise here, it's clear, particularly from that one on the right, that there's a need for looking at trans and non-binary health in general in a more accessible way, particularly sexual health. I think this one was health in general, but this one is sexual health. It might be a bit small for you people at the back, but you can just see there's a large number of even cisgender people who are not accessing sexual health services in the past 12 months. And at the bottom, that's trans women with nearly 90%, so it's huge. So we're going to have a look at a chat about what we did about it in Leeds to help support trans people in the area. The way we approached this was partnership work with Yorkshire Mesmac and the local gender outreach workers from the Gender Clinic in Leeds, and also Integrated Sexual Health Services, Leeds Sexual Health. And we ran community consultations with local trans groups and with the service users of the Gender Clinic to respond to the needs, the sexual health needs of it, and just try and be very open to shape a service by what they needed in the area. So the 3 main things that they came back with were that would stop them attending kind of mainstream sexual health services were, top one was transphobia, as you might expect, a big thing about misgendering. Even if it was expected rather than experienced, that would be enough to stop people from going. Issues with internal systems, this might be a bit familiar for some of you. Systems like Lily, very binary, so you can sign up as a male or female, so it doesn't include non-binary people. And also dysphoria came up in these community consultations, particularly when talking about chlamydia, gonorrhea swabs, even self-swabs. People had discussed how this could be triggering for them and make them not want to do it or choose a different test. So it was useful to have these conversations. And from this, we ran a pilot offering chlamydia, gonorrhea testing and HIV testing to these communities, and that ran alongside a grassroots community trans group in Leeds. And from there, I believe we might be passing over to Maddie to talk about developing the new clinic.
Thanks, Paddy. So, yeah, I'm one of the registrars at Leeds Sexual Health that's working on this, and we run the clinic. It's a holistic sexual and reproductive health clinic once a month. So I run it with a healthcare advisor, but it's on the Yorkshire Mesmac premises, and it runs alongside an existing trans and non-binary support group that's run by the gender outreach workers. So it is all really working in collaboration. And so the idea was to encourage people to come who had misgivings about attending our mainstream services, and to build a relationship with the service users, but also the other organisations. So most relevant to today, we offer full sexual health screening. So by that I mean swabs and urine for your chlamydia and gonorrhea, and then venous bloods for HIV, syphilis, and hepatitis B and C. We also offer offering a high uptake of vaccinations, so Hep A and B and HPV vaccination. So that's getting a lot of positive reactions. And then, maybe less relevant to today's, but also important, we offer contraception, so LARCs, long-acting reversible contraceptions, which many people might want to achieve amenorrhea, to mean they don't have any bleeding, but also shorter-acting methods as well. And then also I offer cervical smears for people with a cervix who have been left off of the national recall or for various reasons don't feel
confident or able to go to their GPs for that. It's really helpful. The gender outreach workers do a lot of work in the community publicising, and there's posters, and we've also involved other team members at the Gender Identity Clinic. So now they send out our poster in their kind of welcome pack to all new people accessing that service. So this isn't quite up to date actually, because I've now got the January figures in. So it's actually, we've had 40 appointments. So it's been exactly a year, 40 appointments with 23 different people. There's been 2 people coming for smear tests and 1 person wanting a coil fitted, but the vast majority have been for STI and HIV testing and vaccination, as I said. So that's our poster on the side there.
Sure. So we'll just whiz through this. The poster that was sent out in the post looks something like that. We're hoping that now they've done that, it took quite a while to go through their systems to get that sent out, that there'll be increased uptake, particularly outside of the group that runs alongside the drop-in. Do you want
we have worked on, as I said, creating relationships with the service users and the people at Yorkshire MESMAC and the GIC. It's also increased our awareness and confidence as clinicians, and I've taken a lot of verbal feedback back to our Leeds Sexual Health kind of mainstream service, our main base, and it's just given us a lot of food for thought, and I'll talk about that in what we're doing moving forwards. One thing to point out as well, out of the 23 people, 17 of them had never been registered with Leeds Sexual Health before, so had never tested under us at all. So that's kind of a previously unmet need, unseen population potentially. And we're hoping that via word of mouth and building relationships, rapport, confidence, that will encourage more people to come to all of our services at Leeds Sexual Health.
So just last note there, we're looking to expand this and kind of copy and paste it into our other services. We've just done a similar thing in York with your sexual health, and so we're hoping to be able to kind of share that learning in other areas too.
And then moving forward, we're going to, now it's been a year, we're taking some time and space to kind of review it and look at all the people we've seen, what people are coming for, and review the registration forms both at the outreach clinic that we're talking about. It's learning as you go along. We've been doing it verbally at the moment. It's been a bit clunky, so we're going to introduce a written registration form, but also, like I said, taking that back to our other mainstream services at Leeds Sexual Health, reviewing those registration forms we use there for everyone. We're getting the gender outreach worker to come to our Leeds clinic to do a walkthrough of a clinic experience, to assess our services and see if there's any improvements we can make. We're working with Lily, as you've mentioned, it is tricky. We're doing as much as we can, so we've not got gendered performers, they're just the same performers. Unfortunately, the registration numbers are still but very much binary F and M numbers, but we've been told they're working on that. And then we're going to try and we've got good verbal feedback from people coming through the clinic. Everyone who started their vaccination courses with us has come back for further vaccines, so hopefully that's a positive sign. And I've heard a lot of, like I said, verbal offhand comments saying this is a good service, but we're going to try and get some more formal written feedback and also suggestions to keep working as a team to create the best and most approachable service that we can. Thank you. Thank you very much. Can each of the speakers please just come back up? So we've got about 6 minutes left for some questions. Just to remind you, because it may feel a while ago since we had the first presentation. So Alyssa had been speaking about MSM STI screening. Phil behind me was talking about black queer men, but also it was actually broader than that in the end, wasn't it? Then we had also presentations around commercial sex workers and newly arrived asylum seekers, and finally over 50s, and then the trans and non-binary clinic experience as well. So quite a massive diversity really of different target groups. You've got some microphones. I think there are some out there. Just to mention that the slides as well of everybody's presentations will be sent out in a link to you, so you will get that information later as well. Does anybody have any questions? And it might help if you say who your question is to, if that's appropriate, if it's for any particular person. Yeah, we have somebody back there.
It's Pete from Metro. I just wanted to ask Pat, with the people that you see in the asylum clinics, how do you overcome A, language barriers, and B, some fears about potentiality of them being diagnosed with, for example, HIV positive, whilst they're waiting for an immigration to be completed?
So was that, I didn't hear that great, but I think it was a question about confidentiality and
It was
question
about
language.
allaying their fears in terms of the diagnosis,
okay.
and also about language barriers, so between the people you're speaking to, so they completely understand.
So the bit that I didn't talk about, and I meant to, we've got like a team of volunteers, and we also have like a paid translator. So it works because of their hard work, really. So we've got someone who can speak a couple of African community languages and French. We've got Farsi speaker. We've got someone who can speak both 2 of the 3 Kurdish languages. And I've got Google Translate on my phone and try and muddle through. In terms of allaying fears, I mean, like, people want to use the service because they've come to the UK. It kind of suddenly feels like the barriers have dropped and there's the potential to sort things out that they've been worrying about the whole time that they've been trying to get here. So like, people are really enthusiastic users of the service. And that goes for all the different things that we offer. And you know, people are hungry to be like welcomed and to be given support because they don't get it in the place that they live in. So there aren't really massive barriers in the way that you know, I used to test a lot of MSM in saunas and stuff, and it felt like there was huge barriers to them coming to test, more so than that community. So yeah, there aren't really massive barriers. I wish we could test more women. I would really like for my female staff member to come back, but she's moved to London and she's sat just there. But yeah, I think that's the answer to your question.
Thank you. Does anyone else have any other questions? No? Oh, yes.
Pardon?
If you were going to test women, have you thought about where you would target?
So there are less women in the initial accommodation centre, and it feels like the majority of asylum seekers that we see are men. But there does seem to be, they seem less up for testing and taking sexual health information from men. So they are there, but I think what we need is smart, friendly black woman to help us. So if you're looking for a job, anyone?
Thank you. Any final questions? No. Okay. So tea is in the Dickens Library, which is downstairs and to the right. But can I join me, please, and just thank the fabulous speakers.
Hi, everyone. Wow, that was loud. Hello? The sooner you stop chatting, the sooner you get to go to the drinks reception. Hi, everyone. I'm Deborah Gold. I'm the Chief Exec at National AIDS Trust, and I'm just here to lead us through this last plenary session of the conference. So thank you so much for staying for this and joining us for this chance to reflect on some of the key issues affecting the future of the HIV sector and really kind of bring things to a close after such a great day. We've got loads of speakers to get through, so I'm just going to move on really quickly and introduce Cham Kefutu, who is one of the project managers from the HPE program, to talk about the work of the last 3 years of HPE. So Cham, come and join us on stage.
Thanks for the introduction, Deborah, and a very big thank you to everyone who came today and who participated. I've been running around trying to make sure there's no catastrophes, but I've heard so much great discussion and conversation, and so I just wanted to take a moment because this program is what has led us all to be here today, the reason why we have this conference, which is a free conference, and which we're very happy because it allows a lot of people who otherwise wouldn't be able to attend these sorts of conferences to attend and get engaged. So I thought it would be a good time to just give us a reminder for those of us who are familiar with the program about what we've managed to achieve, and for those who aren't so familiar, just to get a bit of the background about what we're about and how the program is structured, our approach, and how it's really led to the sorts of impact that we've experienced. So the program, it has 3 main pillars: social marketing, local activation, and sector engagement and professional development. And the program was commissioned by Public Health England, specifically targeting gay and bisexual men and Black Africans in the UK, because they are the 2 groups that are most affected by HIV, although they aren't the only groups, and increasingly we're seeing the communities affected really diversify, and also the cases of undiagnosed going down. Our objectives are to increase testing, to promote condom use, promote other biomedical prevention interventions, including PrEP, to raise awareness of STIs, and to reduce HIV stigma. And the approach that we took, I think, really underpins the results that we've managed to achieve, not only with the communities that we engage, but also with all of the professionals who work in HIV in the UK. Not only do we seek to inform people in the communities about the sorts of tools they can use or where to get a test, but it's really important that we try and motivate them and put the tools in their hands to actually go get a test, or to physically put a self-sampling or a self-test in their hands to do the test, and to reduce as many barriers as possible. Similarly, with our sector work, we don't just say, it's really important that you are up to date with all of the information around U equals U, but we try and enable them, give them training materials, webinars, seminars, so that they have that opportunity to learn and embed that evidence-based practice on a daily basis. Many of you, if not all of you, would have seen National HIV Testing Week, which is our flagship campaign, and it's been running for many years now. And alongside It Starts With Me, it's really the backbone of the program, and it's had a really far-reaching impact because of how it's been structured. And at the heart of it, it's really about putting people who are affected by HIV at the heart of our response, of our public health response to HIV in the UK. And it's about real people telling their stories, and what do we need to do as individuals in our communities, and as professionals, how can we support people in pragmatic ways that meet their needs to really take up prevention methods, get tested, and stay up to date with their medication if they are living with HIV. So in the last 3 years, we've had a really massive reach. We've had more than 500 million opportunities to see. Some of this was paid, some of it was owned and from PR. And we worked a lot with lots of digital platforms like Facebook and Twitter, and print media providers, which are mainly targeted towards Black Africans and gay and bisexual men, but also some general media companies as well. The website is a really critical referral point for the program because we have a lot of tools on it for people to find out where to test, when to test, what condom works for them, and a lot of service providers direct people to it, and we also send people to the PHE self-sampling program through the Starts With Me website. And we had 500,000 website visits and 300,000 tool completions in the last 3 years. As I touched on, National HIV Testing Week, has really evolved beyond us and our wildest dreams. And we've been really, really grateful to get the support of more than 100 diverse influencers who have, made it go further than we thought possible, especially thanks to Prince Harry, Dr. Ranj, Gareth Thomas, and many others who are on YouTube, who have a reach big and small in their own communities. And it's really helped us not just stay focused on, gay and bisexual men or Black Africans, but really bring it into the mainstream, normalize those conversations around HIV testing, because people will never have another opportunity to hear about HIV other than testing week. To drive some of those issues, we're finding increasingly engaging the broader health and social care sectors in HIV prevention, because they are the gatekeepers to these communities in many ways. And it really has been valuable in garnering their interest just as a highlight. And I think it's something we're looking forward to this year and beyond. In terms of the evaluation, Public Health England commissions the independent evaluation through Kantar. And on average, in the last few years, these are the results we've managed to achieve. So we have really, really high campaign recognition, motivation, and action as a result of the campaign, both among MSM and BA. In the 3-year period, during promotion from November to January, we pushed more than 66,000 self-sampling kits to MSM and Black Africans, as well as a few other people. And what was really interesting is a really decent proportion of these people were first-time testers. And we also managed to push 14,000 condom packs, which goes back to what I was saying about, literally putting the tool in the people's hands, which, many of you do on a regular basis, so this isn't really news, but I think I just wanted to reiterate it because it's really the systems approach, everything going hand in hand, which has, had the impact that it's had. I'd like to say a very special thank you to our local partners who helped to amplify the campaign locally and who deliver local prevention work and community-based testing on behalf of the program, and to really support local projects and programs that are locally commissioned. It wouldn't have been possible without you. If you hadn't really been involved, getting the resources, getting them out there to clients and so on. We really want to thank you, as well as providing input into the campaign and what it should look like and what works and what doesn't, which has been invaluable. So our local activation partners, they actually engaged more than 50,000 people, and a really almost even split between gay and bisexual men and Black Africans, and a decent proportion of the MSM were BME, and it was an even split between men and women. In terms of testing, tested over 6,000 MSM and 4,000 Black Africans, and about 17% of the total, about 2,000 people, were neither MSM or BA, but were still vulnerable, like trans people or homeless people, sex workers, and so on. A very high proportion of the people engaged from our local activation testing are first-time testers, which just goes to show that for those who test in community settings, a really high proportion are first-time testers, and they come from key populations, which just goes to show the value of community-based testing services and why they need to persist, because they are reaching really highly in need groups. On average, we had about 20 reactive results a year across all groups that we test. And lastly, we have the third and final pillar, our sector engagement. And we have engaged the sector across what we do. It is a systems-wide program, more than 330 organizations taking part in Testing Week every year. We've held a conference like this in the past. We've had other smaller seminars and webinars with more than 600 participants who really have a very diverse professional profile and also come from all over the country. You know, so this is, generally people find what we do valuable. I think they find it, what the sessions we host, a good forum to learn and engage and network. And I hope that today, when you evaluate this session, you don't bring that down. I hope you keep it up, or maybe push it up to 5 stars. That would be good. Yeah, so I think that's it. That's just a whistle-stop tour. And I just want to say thank you to everyone who has helped support us, and I hope that we've been able to support you and help push what you do go further. Yeah.
Thanks so much, Cham, and no pressure, but if you could say nice things on the evaluation, that would be great. I'm going to invite Simon Collins up to the stage, and I don't think Simon needs much of an introduction, but he's an HIV treatment activist who helped set up iBase in 2000, and he's here to talk to us about the future of HIV technologies. Simon? Simon's going to talk for about 10 minutes, and then we'll have about 5 minutes for questions afterwards. So start thinking about your very focused questions now, so we can get that done.
I thought I was going to talk for 15 minutes.
15 minutes, you're right.
But, just when I thought I couldn't get anything,
overflow.
Just when I thought I couldn't do anything wrong, I've messed up my clock. So, so if I start talking too long,
that's fine. Let me just. Thanks, Cham. No problem.
There's somebody to show you, I think.
Okay,
Oh, no,
cool.
don't worry, there's someone with the time.
Great, cool. So I work at a project called HIV iBase, which is a treatment activist project. We focus mainly on treatment advances. We offer advice or information about anybody in any situation where you think maybe you don't have choices. Usually you do, you have choices to get better care and get better treatment. My disclosure, I've got no personal financial conflict of interest. I'm a community rep, though, on the Rio study, which I'm going to talk about. Can you hear me okay at the back? I think it's great, strange acoustics. And iBase does get some funding for some of our projects from the pharmaceutical industry, for which I'm actually very appreciative. It doesn't stop me being critical when I need to, and it doesn't stop me recognising when we have shared goals where we can collaborate. So every 6 months I update a report which is a sort of review of the next drugs and the pipeline and what's still coming. I need help with my phone. If you want to see any more about these drugs, then this is online. It's going to be updated in the next couple of weeks for the CROI conference, and it's part of a report called Fit for Purpose, which reviews the information we need for the latest drugs to become available globally, including in low and middle income countries. And the Fit for Purpose also includes a pediatric HIV pipeline. So starting at basics, HIV is a virus. In order to establish infection and to in somebody who's not being treated, the virus has to get into one of your immune cells, and then it has to replicate. And in order to do this, it goes through various steps and stages, and each of those stages is a potential target for treatment to work. And current treatment, I should first of all say, is current treatment is pretty good. There's 10 single pill fixed dose combinations, which will, if you're diagnosed early and you start treatment, will give you near life expectancy. And so it's pretty amazing, and I don't know if you can see these from the back, but there's at least 20 compounds that are in the phase 2 or phase 3 development for better drugs and for different formulations. And of those, there's an overlap. My brief was to talk about PrEP and HIV prevention. There's an overlap. The same drugs that are being developed for treatment are also being developed for prevention. And so the few I'm going to pick up on here today, I don't have a pointer. There's one called islatravir, cabotegravir here, and then this big block here is monoclonal antibodies. And that sounds like a scary thing, but they're just a sort of immune-based treatment. So this is what I'll talk about. I won't have very much to say about other formulations, but I'll put a bit in the end about the things I haven't talked about. Just finding out, because current PrEP is already so effective, that sets up new challenges for researchers, for regulatory agencies that approve drugs, and for community activists that are trying to get the best care for people. It's not so easy. Now we have PrEP, which is as near as damn it 100% effective if you're able to take it. And then right at the end, I'm going to include a couple of slides about a very exciting study that's about to start in the UK, which overlaps with HIV cure. So current PrEP, as I said, if you're able to take daily PrEP, then you won't catch HIV. If you're a man and you're able to take on-demand PrEP, then you won't catch HIV. But you need to remember the pre-dose, and the pre-dose can be quite tricky, and half the population at least are women, and the on-demand PrEP isn't an option. You really need, for protection, to get good drug levels, you need to take daily PrEP. So the first compound I'm going to talk about is called cabotegravir. It's from a family of drugs called integrase inhibitors, and the thing that's special about this drug is it's a long-acting formulation, and it's given by intramuscular injection. Before you can have the injection, you need to take a month of daily pills to check that you're not going to have a bad reaction, and then you have a couple of these injections, and then after that, it's every 8 weeks. That's how it's being developed for treatment. It has a very long half-life, which is good because it means that you'll get good coverage in terms of HIV protection, but the downside of that, it means that once the drug is in your body, it's going to hang around for a while, and so you need to have some special ideas about how we're going to be careful not to get drug resistance. As an update, we expected that this would be approved in December, and because of complications in terms of scale-up of manufacturing, it looks like the FDA decision on approval is going to be deferred for a bit, but these drugs will become available. This is what we call the tail. So you take a drug levels go straight up, and then they tail off. And with a long-acting drug, the red line here, which is out to a year, you can see that only about half the people have drug levels that drop off after a year. This is from one injection. You take an injection here, left-hand side, 52 weeks later, half the people in this study still had significant levels of the drug. And you can see the trajectory of this line is it goes out for several years. So there are some people who will have one injection, and the examples we've got is that a man's had this injection and still had detectable drug levels 2.5 years after taking the injection, and for women it might be slightly longer. The reason this is a concern is you start PrEP. We know from daily and oral PrEP that you start and stop PrEP depending on what your risks are and how you need that protection. If you're using long-acting PrEP, even though technically you're not needing that protection anymore, the little bit of drug you've got left means that if you're unlucky and you become HIV positive, you'll become HIV positive with resistance to that drug. And that will mean you won't be able to use other integrase inhibitors, and they're currently first line. So the two studies that are ongoing are large phase 3 studies. These are the last studies that are done before a drug is approved. And most PrEP research now is you'll have two identical study designs. One will be done in North America and South America and maybe Southeast Asia, usually in gay men and transgender people. And then another study will be done in sub-Saharan Africa, usually in African women. These are due to end in a couple of years' time. Islatravir is the second compound I'm going to talk about. It was bought by Merck in 2012, and it was actually developed by the Yasama Corporation, which has been making soy sauce since about 1645. So you get interesting cross-fertilization between different specialities and things. I'm glad they research flavoring for soy sauce, or else we wouldn't have had this drug. And this drug is more remarkable than anything else we've had ever before. It's incredibly potent. The dose that's being looked at for treatment is less than 1 milligram a day. And efavirenz used to be top-line therapy, that's 600 milligrams a day. Raltegravir is 1,200 milligrams a day. This is 0.75 milligrams a day for coverage for treatment. The interesting thing from the perspective of prevention, and there's unmet need in prevention. Lots of people, if you say you're going to have to take a pill for anything, will not go near PrEP. So there's a huge population that's just never going to get anywhere near PrEP, and we've already had some of the other speakers to talk about these issues. So there's two. So one of the formulations is you might be able to have a long-acting implant, similar to an implant hormonal contraceptive, which would give you more than a year's coverage. And the second formulation, which I think is just as exciting, is that you might be able to have one pill a month. And so even people who are really resistant to taking daily pills for anything would find if they're protected from HIV as well as they are with daily PrEP, 12 pills a year or one pill every month is a completely different prospect. Currently in research, there's a phase 2 study going for the oral once monthly pill. And here we're going to get some results out at the end of this year, although these won't be efficacy results. Is that 5 minutes? Oh, good grief. Okay, so BNABs, pronounce them BNABs, they're basically an immune-based treatment that comes from HIV-positive people who several years after their infection realize they have strong antibody responses. Now we're able to turn those into a treatment that can be used both for prevention and for treatment. They directly, as treatment, they have an antiviral effect like other drugs, and they're also formulated in long-acting formulations, which means you might have an infusion once every 6 months. They're differentiated by potency. No single antibody, monoclonal antibody, will cover every type of HIV, so they need to be used in combination. But there's about 20 of them, 30 of them are in research, and hopefully some of them for one family of antibodies won't have cross-resistance to the others. So there's 2 phase 3 large prevention studies going with an antibody called VRC01. These studies started in 2015. Similarly, you have a US and South American study, and you have another study that's running in African women in sub-Saharan Africa. The perplexing or frustrating thing as an advocate is all the experts I know before they enrolled the first patient in this study, did not expect this to produce really very impressive results. This won't be as impressive as daily PrEP, and that brings you up questions for why the studies are being run. But you will have information that's important. It's monotherapy. Actually, the studies were designed with placebo controls, so people don't know whether they're getting active or placebo drugs in these studies. And as an advocate, nobody really should be should be having a prevention study where they don't have access to PrEP. Now we know that PrEP's approved. So although there's low expectation of benefit and placebo design, we'll have some results. We'll have efficacy results by the end of this year, and that's exciting. Other approaches to PrEP that I can't really talk about in much detail, HIV vaccines, where are they? This month, a large HIV vaccine study from the US was stopped early because of low effect, or zero effect actually. But there are 2 other phase 3 studies going with a Janssen mosaic vaccine, and this looks more promising. Again, you have one in gay men and transgender people in North America and one in sub-Saharan African women. Little bits of information, other formulas. You could have PrEP that was just like one of these mint things that you dissolve on your tongue. You can have all sorts of, they're looking at whether you can have a douche formulation, whether you can have other soft implants. So there's other technology that's being researched. The ethical challenges are, if you have something that's 100% effective, how do you prove something else is as good or better? And you can't really. Nobody's got an answer. 2 minutes, right. So there is an ethical challenge. The slides will be online, you can check them out there. But actually, nobody has an answer to this. And the only answer really for the research companies is to move to the areas where there's the greatest unmet need, and that might be in low or middle income settings where HIV incidence is still significant. The Rio study you need to know about is if you give 2 long-acting monoclonal BNABs to HIV-positive people who are on treatment, we have the hope that those people, if they stop treatment, their viral load may stay undetectable for 6 months. You give me an infusion now, my viral load will stay undetectable without treatment for 6 months. That's the hope. The study's about to enroll in the UK. It's as cutting edge as you can be, but it completely changes the perspective in terms of what you think a vaccine needs to be. So we have a vaccine study that was just stopped after 40 years, we still don't have an HIV vaccine, but here you have the potential that these immune-based treatments that are generally pretty expensive, but they could be affordable, might have a really important role for HIV-positive people and for prevention. That's the study, there's a bit of details. It's a small study, 75 people who were diagnosed early and who started treatment early. The summary I don't need to talk about because I've gone through it, and a few thanks to people at iBase and on the Rio study. I'm happy to take questions.
Will you just take the questions?
Okay.
Yeah.
Anybody? Yep. Back of the room.
That was hello. That was fascinating. Thank you. Given where we are with PrEP access in England and Wales currently, of those trials, are any of them likely to come to us off or nearly off patent?
So the big question and issue for development of all new treatment is that now generic medicines are available both for treatment and for PrEP. That's the challenge, is that new and better versions of treatment and PrEP need to recognise that they have to be priced so that we can access them in all countries. And for PrEP, for me, that's the price of a couple of pints and a packet of condoms. And that was the change that actually meant that PrEP rolled out in the UK. And in terms of the model for PrEP, which I would say is at the moment, 40 million people are HIV positive and in need of treatment, sounds like a lot of people. There's 6 billion people in the world who don't want to catch HIV, and that's the global market for things like a once monthly pill or for an implant. And that does become an affordable model. Yep.
I didn't understand why should that be an issue if we have many effective treatments and people can pick and choose what they want to use. Or is it ethical problem, or is it cost problem, or is it just some interested company they want to see their research going on and others not going on? Thank you.
Okay, so companies that are involved in research aren't charities. They have a very keen eye on things that are going to generate income that will sustain more research. So the overlap between community and pharmaceutical industry is I want better drugs, I want new drugs, I want research to continue. And that can happen. The two antibodies that were developed at the Rockefeller Institute, the patents for that have just been acquired by Gilead. And Gilead are a research-based company for these two antibodies, so the potential is that these will become treatments. And each decade of the HIV epidemic, we went from no treatment. 10 years later, we had a few drugs as monotherapy. 10 years later, we had really effective treatment where you had combination therapy, but you might be taking 30 pills a day. 10 years later, you had everything co-formulated into one pill. 10 years after that, we now have 10 single pill formulations. And if you want to know where the future of HIV is, in 10 years' time, I think most people won't be taking any pills. I'm not saying I don't think they'll be cured, but I think there'll be long formulation options, and most people will be using that. And so the research can be better.
What a great ending thing. Thank you so much, Simon.
Cool.
Thank you so much, Simon. And as a brilliant kind of ending thing today, we've got a great panel of speakers that I'm going to invite to join me up on the stage. They're going to each speak for about 4 minutes under the topic of No One Left Behind, so just some kind of introductory thoughts, and then we've got a few minutes for some questions and discussions with all of you before I invite Ian up to close us down for the end of the day. So in no particular order, just sit where you would like to speak. Can I invite Vanessa Appiah from the Barts Health Trust, Luis Guerra, Public Health Specialist and Lead for the HIV Commission, Harvey Kennedy from the LGBT Foundation, Ian Howley from LGBT Hero, Lizzie Jordan from Think to Speak, and Michelle Ross from ClinicU up to join me. Thank you. Oh, sure. That's all right. Yeah. Sorry, nobody just showed me this.
I don't know. If I just do that, that's fine. Didn't work. Okay.
Okay, technology. Okay. All right, well, what they didn't know is that they've sat down and now they get to speak in the order they've sat down. So, you guys, you've got some microphones between you to share. Ian, can I invite you to get us started?
Yeah, so just here from here? Here's fine?
Yeah.
Hi, everybody. My name is Ian Howley. I'm the Chief Executive of LGBT Hero, which is the parent organisation of GMFA, which I'm sure most of you have known. We've been working in sexual health since 1992. When I was invited to talk today, the theme was Nobody Left Behind, and it was a very broad range of subjects of what we could actually talk about. So I want to kind of talk about something that I feel we've been very successful in, is how a very male, white-centric organisation can work with people of colour, and particularly Black and Asian MSM. I don't know how many people have actually seen our Me, Him, Us campaign over the last couple of years. Just so I can get a rough idea, if you've seen the Me, Him, Us campaign, can you raise your hand? Okay, so for those who don't know, Me, Him, Us is a HIV testing and representation campaign that was built in partnership with BME MSM. And it was based off a survey that we conducted back in 2016, which one question was for our FS magazine, which was based around racism and the gay scene. And one of the questions we asked was, does HIV prevention represent you? Does the LGBT media represent you? And 83% said no. Based off the conversations that we had from there, we kind of felt like there was a gap in HIV prevention, and we kind of wanted to work within that. So we developed a plan with Black and Asian MSM. We developed the bid. It went to Gilead. Luckily that they supported the project. And from there, we built in the program in partnership with the men who were involved. And that was really important because I didn't want to, for us as an organization, to be working on behalf of the men who felt representative, but actually to work in partnership with them. And since we began this work, we've reached over 7 million people. We've had over 150,000 extra people come to our sites. We've forwarded nearly 2,000 people to home testing services. But what it's done is it's placed trust in an organization from a group of men who felt disenfranchised from HIV sexual health to be able to work and trust us to be able to work in partnership with them to be able to have a successful campaign where they felt representative in a true form.
My name is Harvey Kennedy. I currently work as a sexual health coordinator for community engagement at LGBT Foundation. I guess I could talk about a bit about the history of LGBT Foundation as well. Come quite a long way and made lots of leaps and bounds in trying to respond to some of those same concerns that were just mentioned around people feeling like they weren't really represented, or that it wasn't really collaborative, or that decisions were being made on behalf of communities that were not being visually represented in the organisation. And I think that was part of some of the most recent work that's been done in collaboration with across the organisation and the community as part of the community asset mapping strategies that we've been trying to develop in partnership with our partners at BHA and George House Trust, but also looking at a lot of BAME inclusion work as well. Again, looking at specific communities, both who have disparities related to their age, as well as their communities of origin, and some of the challenges, the unique challenges happening in these communities by trying to diversify the staff delivering those services. So I think it's been quite a long journey that's had lots of feedback around it that has been even more recently really taken into consideration and put some actions behind it to really visually create a representation that is more conducive to the services we're trying to provide to the community. So I think some of the things that we've tried to do, along with my own role in conjunction with other people across the organisation, is to fix some of the imagery issues of some of the campaigns that we've been doing, to look at the faces and say, well, actually, if you can't see yourself in the campaign, does it really appeal to me? We've discussed that, I'm sure, across the day today, as well as many of the meetings that you're in regularly, but really taking it seriously and saying, if the person's face is not there, we can't then complain and say they're not turning up to testing, they're not turning up to group work and support sort of services. So a recent campaign that we launched was around ending, of course, HIV in a generation, but in Manchester and looking at the populations and the needs of those populations. Putting together focus groups, putting together group work in the community, focusing on men's issues, gay, bi, trans and intersex men, looking at the wider population, trans women, black African communities and 50+ communities to really diversify the programming and not just say that we've planned it, but really try to roll it out, brand it properly, fix the imagery, promote it widely, be there when we say we're going to be there, and really be there if people need us. And that comes along with the upscaling of testing, along with some of the group work we're doing. So it's quite a comprehensive service that has come from a long history of taking feedback, learning lessons, making mistakes, fixing it, working more collaboratively, and taking the advice that's been made available.
Hola, mi nombre es Luis Guerra. Tengo 4 minutos para hablar, así que voy a tratar de hacerlo en inglés para que el resto me entienda. And so I'm going to try to now switch. So I'm actually going to tell you a quick story. And my story is going to be a public health story. And it's about Latinoamericanos and people that look like me. And while I'm telling you the story, I want to give you 4 minutes see if you can actually figure it out, which box do I belong in the census. And if you just take a minute to think about that while I tell you the story. And Public Health England released some data that actually is fantastic. And actually we need to celebrate the fact that it's been, 3 years now consecutively, we're seeing decreases on the numbers of new transmissions. And that's because of all of you. And however, there is a side of the story that nobody's talking about, not even in a platform like today. And this is that there are 2 communities where that decrease has not been translated. One of them is West Africans, and the other one is Latinoamericanos, people that look like me. And so I understand that sometimes we need to actually push pause and celebrate our successes, but the successes of some is not the successes of all. And we are here to try to build the argument that if you don't count all of us, then we will never reach that target of elimination of ending new HIV transmissions. So this is my story. And there is actually 3 local authorities in London, Southwark, Lambeth, and Hackney, and I don't work there, but they actually have broken the norms. They've been quite disruptive. What they have done is they have taken the 18 categories you see at the ONS at the census, and they have added an additional one called Latin Americans. Now, why would they do that? What's the point of doing that? And is it just because you have a sassy Peruvian screaming behind the screens trying to get things to happen? Or is the fact that they saw an emerging challenge and they were pioneers on doing this? So, a few years later, Public Health England does a national self-sampling service. First one in the nation, is worldwide success, and they include that one additional box that says Latin Americans, 18 plus 1. You might say, well, what's the point? I will tell you what's the point. The point is 1.28% of reactive rate. 1.28 within Latin Americans that use the service have a reactive result. What does that mean? Let me put you that into context. 0.98 of reactive rate was among gay and bisexual men. Latin Americans is 1.28. 0.84 reactive rate is among white people. Latin Americans is 1.28. If they would have not placed that little additional box on the service, none of us will have known that right now, HIV is actually a challenge within Latin American communities. So if there is one thing everybody in this room can do to actually to not leave me behind, leave people like me behind, is give us a box. The next time you build a service, give us a box. It's not that hard. Thank you.
I'd like to say hello and represent everybody that's outside the M25. I think I am that contingent today. I've got a couple, 4 points really. First one is around accessibility and inclusion. What do we actually mean by that? And I could take today as a great example when you look at the venue that we're in and how accessible. Does that really flow through as the golden thread in all that we do? That should flow through and should echo in every single piece of service design and delivery that we do. And perhaps a venue choice like this shows that maybe that isn't quite there yet. Again, if we look at accessibility and inclusion for trans folk, which I'm sure Michelle will talk about in much more expert level than me, this should be a national scandal there, and that needs addressing and talking about. The second one, respect. Where is the respect for the grassroots organisations? The people who are doing the work. They're building relationships, they're building communities. That's not KPIs, that's not data, that's relationships, that's people. And we know that that takes time. It takes time to go deep, to penetrate. It's not shallow, and it's not a quick withdrawal. Education does take time. We have to then think, when we're talking about HIV, that it's littered with misogyny and homophobia, particularly where we've got women doing work. When we then talk about the grassroots, where are we really actually funding that? Where are we mobilising our mutant hope machines, as we talked about this morning, who are actually getting the job done? We're chasing and chasing after innovation, and we have amazing programs that are working. If we can invest in core costs rather than project funds, then I think we can really make some change. If we can embed social return on investment, which from my third sector hat of running a social enterprise is key to what we do, it should become business as usual for all third sector organisations. And I think us in the HIV sector are sometimes a little bit behind the curve on that. My final point is who is at the table? Who is in the room? Are we truly investing in the growth and support for the advocates and leaders of the future? Can we hand on heart say we're making that happen? Are we making a space at the table for them? I would quite happily move over and give up my seat. What I want to do is help fulfill this seat. And so we've got this pipeline of people coming through who deserve to be here. Dame Ingler said this morning, we need different people around the table. And I would like to leave with that point. We need different people around the table.
Hi everyone, my name is Vanessa Appiah. I'm a consultant in sexual health and HIV. So I'm here as a clinician, but I'm also here as a Black African woman, and someone that, if you know me, if you speak to me within 10 minutes of it, you'll know that a big part of my heart is in Ghana, so West Africa, and what I claim to do, so that's a big part of me as well. And I just want to talk about some work that I did very recently and quite opportunistically with a number of people from across West Africa. And I talked about, if I had an opportunity to be in a room and to talk about what you wanted me to convey, if you don't have the seat at the table at the moment, so if I have an opportunity, what would you want me to get out there? And actually what happened was 4 themes came out, and I'm going to call it the 4 A's. The main thing that a lot of the people that I talked to wanted me to articulate is that we can talk about all the health promotion, PrEP, U equals U, etc. You can get all that messages out there, but really see the populations that you're speaking to. And it's not just visually seeing them in posters, etc., actually seeing them. And seeing that if we're looking at West Africans, we're not looking at one population, we're looking at a heterogeneous population with many different drivers influencing their behavior, mindsets, etc. And what underpins everything that they've said is that there are clear structural inequalities in our country. There are clear structural inequalities that are affecting people's lived experiences, and we don't talk about this enough. And the aspect is that I'm not expecting anyone here to have the answers, but I think the key thing as we start initially is acknowledge it. Acknowledge it's there, not only within that acknowledgement about it, but advocate for it. So say that I don't have the answers, but I'm acknowledging it, I'm advocating it, and then also amplify that message. Say that there is a problem and that we need to act on it. So no matter what we're doing, we need to support people with their housing, with their education, with poverty, etc. If we don't target those, nothing will move forward. And once we acknowledge, once we advocate, once we amplify, we can activate those populations and we can see the change that we need. Thank you.
I'm just trying to turn this on. What? Oh, it's on. Oh, can you hear me? Great. Okay. I'm just blown away by the speakers here. And before I talk about a few issues, how many people have heard of Clinic U? Oh, okay. And how inclusive is your data collection? Answer that by raising your hands, please. Inclusive trans, non-binary, and gender diverse people. Oh, we're making some headway. Great. I've been involved with HIV for 32 years, and the reason Clinic U came about was in response to HIV for trans people. Well, that was initially the sole reason, but we knew it was wider issues than HIV and sexual health. And we've had 6 conferences, and at the heart of the conferences is our HIV and sexual health. And if we just did that, a lot of trans people wouldn't come probably, but we wrap it round with a lot of holistic and well-being issues that trans people are interested in. And it's not sneaky, it's about bringing this to people that are often never been reached. And that was one way that we reach people. And earlier on we were talking about trust, not here, in another session. And when we set up Clinic U, we thought, well, why should people trust us? We're trans, why should they trust another sexual health service? So we went out to our communities. We focused solely on our communities, on trans, queer, non-binary, gender diverse people. Because if it doesn't speak to me, I ain't listening. And I know we are saying, let's normalize these issues. Let's reach everybody with lots of different images and different poses. But if it doesn't speak to people, if I haven't got trans, non-binary, and diverse, gender diverse somewhere in there, why the hell should I put my eyes on it? Why should I? Because the health issues for trans people are systemic. They are societal, they're institutional, and then they impact on the self-worth, on the self-stigma, that I am not good enough. No one sees my health. When I go to access health services, they don't see me. And that includes the services that we provide. I don't mean Clinic U. I mean the services that we as sexual health and HIV provide. They might not go to that. And so how do we reach communities that are or have been left behind? In 2017, or before that, we worked with Public Health England and Barra Dibaj to change that Hearts HIV and AIDS recording, how long, I can't see that, okay, system to be inclusive of trans people living with HIV or accessing HIV care. And the latest figures were 178 trans people accessing HIV care. Well, we know there's hidden data in that because of historic misgendering, and trans people recorded still misgendered, and they're a lot gendered than they are. I made loads of notes here, but I'm not getting around to them. So how do we actually reach people? Because trans people are not hard to reach when you know where to look. I'll stop there.
Thank you so much. That was 6 really fantastic speeches, and they've also incredibly all kept to time, so we do have a little bit of time for questions and discussion. Is there anyone in the room that wants to say something or ask anything? Wow, you're all tired at the end of the day. No? Okay, I'll move us on. Just in terms of rounding up, I think what I kind of found really interesting about 6 really different speeches is there were definitely some themes that you could kind of see running through them. And so just lots of talk about the importance of partnership, being reliable partners, being open to hearing about mistakes and moving forward. I thought if you don't count us, we don't count, was what I was thinking. And Lewis's call for give us a box that could have been almost just as relevant to some of the things that Michelle was saying. Some of the importance of relationships, the time that it takes to build genuine relationships, and if things matter, and if we really want people to have space at the table, we need to give them the time. And being open in a conversation about structural inequality and really acknowledging that. I thought that was really powerful, Vanessa. Thank you. And I thought, in terms of what lots of you were saying, some of those issues around housing, education, poverty, well-being that Michelle was talking about are so linked together. And certainly we know in our work at NAT that if you can't separate those things out, you can't solve HIV without seeing it through the lens of all of those other things. So thank you all very much for helping to bring us to a close. And now I'm just going to invite Ian Green from THT up.
Thanks very much, Deborah, for facilitating that last session, and for the amazing panellists who have thought very carefully about their contributions, have been extraordinarily thought-provoking. And I hope we all go away and reflect on what we've heard throughout the day, but particularly from this last session. Can I take this opportunity of thanking you all for participating so fully today and for your engagement. It's really important when we hold these sorts of events that we hear your feedback, but also that we can sense from the vibe around the conference centre that there are people are being provoked by what they've heard. And so I hope you'll take away some really positive things from today. There's some thank yous that I want to make. First of all, to the amazing team that have brought this together. Chaku, who's responsible for HIV Prevention England, who I don't know, he's at the back. Thank you, Chaku, for all of your work. But in particular to Alex and to Cham, 2 younger members of the staff team who have organised this programme. I'm so incredibly proud of you. Thank you for bringing this together. We've been really pleased to have some sponsors today, so thanks to Pasante, to Owen Mumford, to Vive Healthcare and to Gilead Sciences and for their financial support. And as a result of that financial support, there's a drinks reception. And so as we finish here today, there's a very short walk to the Wesley Hotel just by Euston Station, and there is a map in your programme, so you don't get rid of your programme yet. And the drinks reception will start at 5 o'clock. Again, thank you all for coming. When you do leave the drinks reception, have a safe journey home. Thank you very much.